So good evening, doctors. I, Shumon, on behalf of Shield Healthcare, welcoming you all in another session with IHERA, International Human Embryology Research Academy, in association with Shield Healthcare. And today's the theme of the program is sperm DNA fragmentation, known and unknown facts. So it's my honor to introduce our today's coordinator. Yes, Ms. Yoshida Tanwar, Madam. Madam is the clinical embryologist with 9 years of experience. She has worked as a senior embryology lab in Church, New Life India Fertility Clinic Private Limited. She is the ASR certified clinical embryologist and certified in advanced skill set embryology training conducted by Mark Center of Excellence in Clinical Embryology, Kasturba Medical College, Nepal, India. And she, Madam, is the member of ACE India and ASRM Society, and she is also a team member of IHERA.
Thank you.
And the next coordinator is Nancy Sharma Brahmabhat, Madam, and she is the Chief Embryologist and Lab Manager, Department of Reproductive Medicine, IKDR CITS Hospital, Civil Campus, Ahmedabad, Gujarat. Madam is the ASRM certified embryologist and certified from ASRM in fertility preservation for reproductive health providers, embryo and blastocyst biopsy training workshop from Embryology and PGD Academy UCL, the embryology certification course from Indian Fertility Society, and she has more than 7 years of experience in the field of ART. And apart from that, Madam has more than 13 research papers in international peer-reviewed journal as a presenting authors, and she is presently pursuing her doctorate, and she did her postgraduate in molecular biology and biochemistry from Guru Nanak Dev University, and she is the member of IHERA involved in gamete alert. And apart from that, Madam is the member of prestigious national and international societies like ASRM, ESHRE, ACE, and IHERA. So next coordinator is Dr. Deepu Gupta sir, sir editor MSc in biotechnology. He is the senior embryologist at Southern Fertility and IVF, Basant Vihar, New Delhi, and he has more than 10 years of experience in the field of ART. He has already trained in the IVF and ICSI and member of Academy of Clinical Embryologists and team member of IHERA, and he has a special interest in vitrification and andrology. So with this short introduction of coordinators today, I would like to hand over the session to Yoshita Madam for further proceedings. So thank you very much. And over to you.
Thank you so much. Good evening, all. Welcome to IHERA Society. This time, IHERA comes with the theme of sperm DNA fragmentation, known and unknown facts, where we are going to learn about sperm DNA fragmentations, their impacts on embryogenesis, preparation methods and techniques, and followed by the demos. So before we begin, I introduced Dr. Ved Prakash sir. He's a founder of IHERA Society. He's a lab director at Southern Fertility and IVF Delhi NCR. He's a president of Academy of Clinical Embryologists India. He's a member of Virtual Education Committee. He visiting faculty in MSc in ART Mysore University, faculty fellowship in ART MIT University Noida. He has contributed 8 chapters in textbook and published papers national and international. Next, I welcome our co-founder, Dr. Sanjay Shukla sir. He's a lab director at Baheti Hospital, Jaipur, and Shivani IVF and Fertility Center. He has done his PhD in life science, working in the field of human reproductive since 1998. He's a vice president of Academy of Clinical Embryologists, chairperson in ACE, India. He's also an editor of a newsletter of Academy of Clinical Embryologists, India. Next, I introduce Dr. Charudat Joshi sir. He's MSc, PhD in life science. He has done special trainings in laser assistant hatching from Belgium. He has done PhD PGD training from Germany. He's a medical director at the Gene India ART Bank. Welcome you all, sir. So before we start, I welcome Dr. Ved Prakash sir to say a few words. Then moderate the first lecture.
Thank you, Yoshika. Thank you so much. So, as you know, iEra is continuous doing so many webinars and educational webinars for everyone. It is free to attend for everyone, and we are committed to introduce many new things, the advancement in IVF. So this time we have one DNA fragmentation. We thought it is, that everybody is in dicey situation. We have to do this DNA fragmentation test or not. So today we thought to take the webinar on that, that DNA fragmentation, known and unknown facts. So today we have Dr. Akash Agrawal. Can I see for the CV? Who's going to? Yeah, please. Yeah. So Dr. Akash Agrawal is MBBS HRA certified clinical embryologist, scientific director, Hector Fertility, Hyderabad, an alumnus of Osmania Medical College, practicing male infertility and embryology since 2011, topper HRA clinical embryology Vienna 2019, and actively involved in academics and has co-authored a book chapter. He is an active member of National and International Faculty Organization, HRA, ISAR, IFS, AS, and participated in multiple national conferences as faculty, and his keen interest in male fertility treatment with surgical retrieval. So today, Dr. Akash Agrawal will highlight DNA fragmentation role in male infertility. Over to Akash.
Thank you, sir. Thank you for the kind introduction. Good evening, all of you. I welcome you all, and hopefully it will be a time which is worth spending. We have been going through about sperm DFI. It has been like the hot topic for most of the times. People will be like, DNA, kuch problem hua hai on the male side. They'll be first thing, they'll be looking at count, motility, and volume, and next is DFI. Get the DFI done, get the DFI done. So we'll see whether in my topic, I'll try to be as concise as possible because it's a bird's eye view of the topic. So I'll not be going into much details about the things, but I'll try to share the clinical point of view, what the important points would be, what the pros and cons. So whenever we think of the male fertility, I always try to divide it into three parts. One is the sperm production part, which your hormones from the brains constitute, your HPT axis, hypothalamic pituitary, testis axis, and your testis is the major source of the actual and the only source of your sperm production. And next comes your sperm maturation. It happens with the accessory sex glands and the epididymal. And next your sperm deposition. So each one of this has a role to play when it comes to DFI as well, and see how it will be in the further slides. So whenever we think of the male fertility, the cornerstone, no doubt, is your semen analysis, your semen parameters in terms of your concentration, motility, morphology. So what is the purpose of the male genital tract and the sperms in particular? It is mostly majorly to deliver the complete, intact, haploid DNA safely to the female counterpart, which is the oocyte. And you can think it like ideally it should not be without any damage. Some kind of damage is there, little damage is possible, but as far as possible to minimize the damage. So that would be the ideal purpose of the male genital tract. So we have a wonderful guidelines from WHO. Your 2010 5th edition was a very good book with that, which standardized your semen analysis across the regions, different geographical regions across the world. And there's a 2021 edition, which is the 6th edition. And you can see I've highlighted the points with respect to your 5th lower centile as the normal parameters, the low reference range. And they are not much change you can see in terms of volume, concentration, just a couple of points here and there. So more or less they remain the same. So which indicates the robustness of this system being followed. Then the question comes in why we should do a DFI at all. What is the need to do DFI, the sperm DNA fragmentation index? Why we should do it all when we have such a very good book which standardizes it across the regions? The first reason is there's a considerable overlap between your fertile and the infertile male with respect to your regular semen, routine semen analysis. It doesn't differentiate quite well between who is fertile and infertile. Your 14 million, 10 million could have a father, a child normally with a natural conception without any interventions as such, whereas someone who's having might be 40, 50 million might be having a male factor over there. So this is the reason why we need something else other than your routine sperm analysis, and you require advanced sperm analysis. And obviously we need to search for that elusive normal sperm which is going to result in a healthy live birth. So what are the various advantages that we are dealing with is the ROS, sperm function test, sperm aneuploidy test, and the test for the sperm DNA integrity. These are the various tests, and today we are going to see in detail about the test for the sperm DNA integrity and the DFI in general. So coming to the structure of the human chromatin, your human DNA is usually composed of your histones as the proteins which are there, which protect the DNA to a large extent. But these has to be replaced with protamins while they are forming the sperms. And this replacement is usually to the extent of 85% in the humans, which is unlike in the other mammals where it goes as high as 95%. So once these protamins come into play, what will happen is the structure of the DNA will change from the solenoid to a toroid, something which is more open and accessible to something which is more compact, which is more open, obviously more open to damage as well, to something which is much more compact over there. And this prevents the damage to happen. So as you could see, it is only 85% that in the humans, so it gives more chances of damage to happen. And again, there are the P1 and to P2 ratio, which is there, which is different in the humans, unlike other mammals like moles and rats, and definitely the chances of damage would be more in humans. So we are speaking always about DNA damage, DFI. What constitutes your DFI? Your majorly, we can classify it as single strand breaks and a double strand break in terms of the DNA fragmentation over there. And how does they happen? They happen by hydrolysis, by oxidation, by alkylation, and sometimes there might be a mismatched base when they can't align together. So this is a slide where I have put together the factors which we can briefly divide them as, broadly divide them as your intrinsic factors and your extrinsic factors. Your intrinsic factors are your abortive apoptosis, your defective maturation, which could be there happening, something to do with your topoisomerase activity being excessive, which will lead to this abortive apoptosis over there. And there might be a sidewise ligase activity happening over there. Defective maturation can also obviously lead to your mode of DFI. And in addition, you have certain parameters over here, certain things which will cause to lead to increase of your DFI. Your abnormal sperms could be there. There could be stasis in the epididymis, your varicocele, smoking, pollution, drugs, diabetes, cancer, systemic pathologies, to name some of them. So they can be amenable to treatment. So your origin of chromatin defects, I've just summarized what is over there. Your defective chromatin packaging is one of the main cause, which is the internal cause. Your abortive apoptosis is one. Next, external would be your oxidative stress and deficiency in your recombination. These are once again highlighting what are the various contributing factors. In addition, you can see something like FSH deficiency, which was a hormone which I put in the first slide, one of the major hormones in addition to your testosterone, your radiotherapy, your chemotherapy, your testicular cancer. One important thing would be iatrogenically, where certain of the times when we might, rather than decreasing, we might increase the DFI. Something which will increase your ROS can always have an increase in your DFI as well. One example I have put in among all the factors is how the factors might vary over time from conditions, so how they would vary. One of the best example is related to the age, which is non-modifiable factor. Whenever we think of in medicine, we think of factors which are modifiable, which are non-modifiable. So non-modifiable, obviously we can't change, you can't help it. If the DFI over here as shown in the slide is increasing its age, you never will be able to change the age of the patient. So the DFI is going to increase. There are many papers which show that your male, the DFI in the males will increase specifically above 40 or 45 years of age. And it is much more tightly bound and much more relating over a period of time rather than your seminal parameters like count motility, which fluctuate quite regularly. And you can say even from sample to sample. So DFI is much more stable over a period of time. Next, coming to a slide where I have put down what are the predictive factors. We have seen what are the contributory factors in terms of what can lead to increased DFI. Now, how can we say whether the DFI could be more, could be important or not in such cases? So you have your type of DNA damage. Your DNA damage you can classify as your single-stranded DNA damage versus double-stranded. Single-stranded, only one strand of the DNA is damaged. Obviously, double-strand breaks are there, which are much more damaging, which are more difficult to repair, and definitely much more of considerable importance. Next would be your percent of sperm with DNA damage. We have lectures coming up for that, where the various tests are there and they will be elucidating more over in that lectures. You have extent of DNA damage per sperm. It's not just the DNA damage sperm, what is there, but how much it is damaged. You have something in some of the tests, you have something called as high stainability index over there. So sperms which are damaged to what extent, whether to a small index or to whether to a large index they are damaged. Obviously, it's something which is damaged to a much more level, has much more harmful and deleterious side effects, adverse effects would be there. Next, whether there's any combined nucleotide damage, where I showed there could be a mismatch could be there, or there could be replacement of the nucleotide could be there, when in such cases, it will further aggravate the damage. We have whether the damage has happened in the intron or the exon area. We know that the DNA is not a homologous thing, homogeneous thing. It is obviously heterogeneous, where you have the functional part, the exons. So something which damages the exons, you can see the changes to happen much more rapidly. I mean, you can see within the few generations, you can see the changes being happening over there. Whereas for introns, still the role of introns, we don't know whether they are housekeeping, how much effect they have, in what way they affect. So obviously something which affects the introns will also have effect, but might be in the later generations, might be lesser effect, which might be cumulative. Next, we have seen how the age affects the male side of it. Then definitely age affects the female part of it. Then the question would be, how would it affect? It's a known fact that the oocyte can always repair the sperm DNA damage to a large extent. Of course, if the damage is beyond the repairing capacity of the oocyte, that's when the problems comes to appear. And this ability of the oocyte to repair decreases with ages. So what does this imply clinically for us? It means that whenever we are going to see a patient who is having high DFI, if the partner is relatively young, female partner is relatively young, then that oocyte is going to compensate for that, and you are not going to see that much of effects or effects of the high DFI. Next, what is the type of DNA fragment test that you are going to use for it? Is it going to be your SCASA, your tunnel? Because what test does is there are different type of tests. They are actually predictive of the damage that has happened over there, or they can test for whether what is the potential for the damage. So no two tests are similar, and definitely the test will have its own implication and its own cutoff level. Your sperm processing in ART, as I have told, it can increase and decrease the DFI as well. And obviously your oocyte number, obviously the more the number of oocytes, the more the chances that you select a sperm has been selected to fertilize, which is having less of a DFI, the better the chances of the outcome. These are the various tests. I'm not going to deal with them. That's a part of one of the interesting topic coming up next lecture. But I would definitely highlight the last four ones: the SCD test, the COMET test, the tunnel test, and the SCASA test. This is a beautiful comparison that has been done between the four tests, the type of damages that to detect, the pros and cons, and what is the cost factor, which definitely would be one of the considerations. Next, how does this, what does the cutoff level signify to us? How do they help you? So they can help you in natural conception, people who want to try naturally, who are probably for idiopathic infertility. Then you would see that tunnel is one of the tests which shows the actual damage that is there in the DNA, which is present over there, the single stranded or the double stranded damage, which is over there. And they have found that when you take as 12% as the cutoff for your tunnel test value, when it exceeds that, the number of pregnancies decreases. Rather, in this study, they did not find any pregnancy at all. And similarly, they have defined the cutoffs for 18% up till 80% for IUI, and anything more than 18 to 30% with IVF. And once the damage exceeds 30%, the chances drop drastically with the tunnel. And in terms of this comparability, your SCASA, your sperm chromatin structure is much more lenient in terms of the limits that it sets to, and it has some prognostic implications as well. One slide I would like to highlight over is the ROS, reactive oxygen species. Though not a topic of my talk today, why I would like to say is the factors which cause an increase in ROS, most of the factors will cause to an increase in DFI. And actually oxidation is one of the reasons for your high DFI. So you definitely need to keep in mind whatever the factors which affect ROS are going to affect your DFI as well. And why is your DNA test integrity important? We have been talking about how to find what are the tests which you will be doing, then why you should do it all. Because there are studies which have shown that once the sperm DFI is high, it can have an association with the semen parameters. It can lead to probably a compromised fertilization rates, probably a poor embryo quality down the line. Next, probably the embryonic growth is not going to be that high. Your implantation rates might be on the lower side. There might be an increased pregnancy loss. So you could see that I was telling for all this, it might be, and we'll see why. What are the indications? Obviously, any case with male infertility diagnosis prolonged whenever they're having, in such patients, any cancer patients who had the radiotherapy and chemotherapy, whenever we are going to use assisted reproductive technology techniques, then in such cases we need to see. And more specifically, we need to see in patients who are having embryonal loss, pregnancy losses, and improper embryo development. So what are the various interventions? Now we have seen in whom to do, what is the reason we want to do, then what are the various interventions that we want to look for in the high DFI patients. Whenever we look for in the high DFI patients, we should think in terms of treatment. And whenever we think in terms of treatment, we should think in terms of the cause, if there's any cause for it, whether we can correct that. So when it comes to the high DFI treatment, we can divide broadly them as something which we can do before the actual cycle begins, pre-fertility treatment, where you can have decreased abstinence, repeated ejaculations could be done. You have your antioxidants therapy, you have varicocele correction if it is of grade 2 or higher, especially with the high DFI. Lifestyle modifications could be done. You have seen that smoking and pollution and other things usually cause an increase in the DFI. And you see below that the recombinant FSH therapy even has been advised by some that it can reduce your DFI. So whatever factors I have put in the first slide, now we know that why they are important right from the production stage, that it can affect. Whenever something is playing a role in the production, it can have an important role in the treatment as well. So you have seen whatever I have rounded off, these are the modifiable factors where we can correct them, where we can get a hold of them. If there is the cause for the high DFI, and we can probably correct and treat them and result in a better chance. So these are some Cochrane reviews which I have put. What are the various interventions which I have highlighted which can reduce your sperm DNA damage prior to fertility treatment. The use of recombinant FSH, they have done a study where they have take a baseline of the sperm concentration and the morphology and the DFI initially, and after 3 months of the treatment. The first 2 columns to your left, this is with the RFSH treatment, and this is as a control group. And you can see that as the time progresses after 3 months, the sperm concentration has not changed that much drastically, but you can definitely see a change in the DFI, which has dropped by nearly 50%. There are various studies which, when we go through that, what is the level of evidence which we have for lifestyle modifications, you can see a level 3 evidence. For reduced abstinence, it's a level 2 evidence. Quite a large data, you can see quite a few papers which have been coming up in the last decade or two. And next you will be having in terms of your oral antioxidant therapy, which is one of the relatively better one. You have a level 1 evidence for it. Your weight loss, not that much of evidence, and diet modifications. With antibiotic, obviously they would help whenever there is a proven case of infection. So you can see that there's a variety of a level of evidence as far as present studies are concerned. They differ in terms of whether it's good, bad, or moderate. And you can see that the level 1 is there only for antioxidant therapy, whereas for the diet and other lifestyle modifications, it's not so much. While we'll be concentrating mostly that change your diet, change your lifestyle. Might be it has an effect, but we are not properly looking at it. Next, you have all these are with respect to your oral antioxidant therapy. Again, there's a fluctuating. We have seen level 1 earlier. Now these studies are towards level 3. And again, evidence towards level 3 over here. And varicocele, you see level 1 in only one of the studies. Most of the studies show level 2 and level 3 as the evidence for varicocele correction. So you see the data is there, so much of data is there, and the data is conflicting. That's where the problem comes. If the data is whether less or more and it's not conflicting, it definitely shows we are going in the right direction, and there definitely is some problem. But right now the data is conflicting. We don't know whether it's correct or not. What we are pursuing so much as probably a holy grail in terms of DFI, whether it actually is that holy grail or not. So coming to the next part of your high DFI during the ART cycles, your sperm preparation methods, which we are again is a part of a lecture later on, your sperm selection methods in terms of PIXI and IMSI and your testicular sperm for high DFI. Yes, your studies have shown that this is a relatively better one. Most of them you can say it's level 3, level 2 of with them, and with testicular sperm it's slightly better in terms of level 2 in a couple of studies. So with so much of confusion, level 1, good, bad, moderate, not sure what can happen, the factors that can lead to. There's been this beautiful paper which has come recently last year, a couple of years back, and it tells us that evaluation, when we should evaluate the DFI. You can see most of the indications what I've told are over there, but then you can see the recommendation is a grade C recommendation. And next comes your treatment approaches. Whatever I have highlighted, again a grade C recommendation. Varicocelectomy, thoda about little better, grade B to C. Again, when it comes to ICSI and miscarriages and previous miscarriages, again, it's grade B to C. So not that great outlook as of now, what we have over here in terms of DFI usability clinically. And then the European Association of Urologists have come out with the guidelines in 2021, where they have said that the DNA fragmentation is obviously one of the novel biomarkers, which is there, and its role has to be further evaluated. Your stimulation therapies, your RFSH or other hormone therapy is still controversial according to them, and your sperm retrieval and antioxidants as such they have labeled it as empirical straightaway. And your TESA for non-obstructive patients, azoospermia, still it's a low quality evidence as far as the predictive tool is concerned. So this is one paper where I've showed we have been dwelling about what impact it has in terms of your success rate to pregnancies, but we are not being limited till the pregnancy. We don't want We want to go beyond that. We want to go to live birth. We probably want to look at what effect it might have on the mother in terms of that. And if we have to want to look how it affects the newborn as well, because at the end of the day, what we are doing is going to get vertically transmitted. It can have transgenerational effects. So this is a good paper, good step in that direction by Rivera et al. And they have said that your pregnancies with elevated DFF, there's an increased chance of gestational diabetes and preeclampsia. Yes, the sample size was limited, but the odds ratio are increasing. So this needs further investigations. And as far as the neonatal is concerned, there's not much of a change in terms of APGAR and NSU admissions over there in terms of the birth weight and when they are born. But we are dealing with the minute. You see, what happens is whenever there's something which is drastic happening, you can see the effect to be there present immediately. When you see a chromosome missing, there would be a aneuploidy over there. Then you would see the immediate effect in terms of pregnancy rates itself. But this is a much more subtle defect which is taking place over there. So the defect for it to manifest itself, it might take some time. It might take one generation. It might be the future age, later age adulthood, it might have an effect. There might be epigenetic changes are there which are being documented in high DFI patients. There are methylation changes which are happening over here. So these future generations we need to think of, and we need to move in that direction as well, and not just limit ourselves to the present pregnancy rates and the neonatal births. So there are some SWOT analysis has been done by Dr. Ashok Agarwal et al. This paper in 2020, where you can see the strengths is obviously it gives us what factors cause it, how we can detect them, and what are the interventions, what we have been seeing the strengths so far. But at the same time, they are having the DFI as an inborn weakness, that there is no universally agreed cutoff till now. And we are trying to justify something with level 3 and 4 and studies which are contradictory, which I tried to highlight over there previously. And whenever you have a weakness, there's always an opportunity. What is the opportunity? To come out with better tests, to come out with better research and move in the direction where the DFI is going to help us. And threats at the same time, DFI is not recommended for all, and might not be covered by some companies as such, might not be that much of a consideration in Indian scenario, but definitely a consideration in the Western scenario. And they don't include all the clinical settings that might benefit from testing the DFI. So this is a summary of what has been known till now, what is the various tests when you should do, how you should collect the samples, what are the various cutoffs which we'll be seeing in the future lectures, what are the recommended indications for each of them. Most of them fall into grade 3 of them, grade C of them. You should be evaluating the male and the underlying factors. Look for any lifestyle changes whether you want to do. Tailor make it according to what is the condition, what is the level of DNA fragmentation, what are the previous treatments taken, what is the results of such treatment. And then if they persist, then you can consider ICSI. And next would be testicular sperm for ICSI, if failed ICSI. Yes, the level of evidence is less, but this is what we have as far as DFI is concerned presently. So the drawbacks, what I've been telling, in addition to those drawbacks, it is that the repairability of the DNA, we don't know. There's always a DNA breaks or the DNA fragmentation is there, but always they could be repaired over there. Like I said, the oocyte itself can repair. Might be the damages in the intron region, which is not so much important clinically. So that's one of the drawbacks. Next, we don't know the oocyte's capacity of repairing. Next would be whenever we are trying to do the DFI by all the methods, whatever we are doing, we are killing the sperm. Thereby, we render it useless for you in the ART process. So we probably have to make technique with the single sperm. We can know whether it is having less of DFI, and at the same time, we can be sure about it and able to use it. Yes, there are certain techniques like IMSI, might be the pole scope where the birefringence is taken use of, but they are not that well standardized. And that's the next point, which is that they are not well standardized. So obviously the test values and the clinical utility always come into question once it is not been standardized well. So what is the final take-home message from this lecture? What I would like to highlight is sperm DFA is definitely a novel marker, which is emerging still, and it requires further evaluation, but it is definitely not for all the patients. The present data indicates that the male with high DFI may affect their outcomes, and various modalities of treatment are available. Though the promising prospect is there, the treatments are available, but validation still needs to be done further rigorously, and we need to come out with better levels of evidence so that DFI becomes a time-tested tool, how your semen parameters have become. And on a last note, you have to always consider in terms of the next generation and the future generations whenever you're implementing any technique, and not just the present success rates. Thank you everyone for patience.
Thank you, Dr. Akash.
Thank you, Akash. Excellent presentation. Actually, you have completed all these things in a nutshell. So there are few questions which are coming in my mind related to your presentation. One in one slide you mentioned that there is a iatrogenic causes also there in increased DFI during the sperm preparation. Can you highlight on that point?
So usually when we go in for the double density gradient method, there can be increased oxidative stress could be present over there. So with that, especially when we don't apply the swim up techniques, it could cause. And when there are temperature fluctuations over there, they itself can lead to your increased ROS and increased DFI as well. So these were the two things which I can highlight.
So what do you want, what is the message you want to give us during that preparation, what one should
you should be more careful with respect to what your timings are, what your culture conditions are going to be. And whatever will lead to your increased oxidative stress can lead to increased DFI as well. So for DFI, it's not that well standardized as of now in terms of your preparation methods. But yes, when oxidation itself is a factor which can lead to increased DFI. So whatever will lead to an increased oxidative stress on the sperm is going to lead to an increased DFI as well. Yes, the methods are there. There are many studies which have proven that once you go in for a swim up, the level of your DFI goes down drastically, especially. And again, there are some studies which compare your capacitated versus non-capacitated sperms. Obviously, the capacitated they found actually has a certain more level of damage. Might be the process which is taking place over there is causing that. And you have various techniques like MAX and Microfluidics, PIXI, IMSI for sperm selection. Obviously, these are to reduce your damage, your percentage of damage. What all these tests does, what we are applying, what are your sperm preparation methods, they actually reduce your percentage of your DNA DFI. They don't tell you which sperm is not damaged. So that's one of the drawbacks over there. So that way, that's the need of the R as far as DFI is concerned, because whenever we are doing ICSI, we are going to select one single sperm. So we are saying ki 10 sperm hai, to usme se, earlier there was 3 damage, now there are going to be only 2 or 1 damage, but which one is damaged, we don't.
Yeah. So second question is there, what can be done to reduce DFI in aged male? Like more than 45 year age male.
So DFI, the studies have shown that there is an increase in the DFI. The various whatever procedures what I've told for reducing the DFI, that can be done. Starting with simple things which don't cost anything, like a decreased abstinence could be done. So collect this, ask them to ejaculate on the day of trigger, the next day, and even on the day of ICSI or IVF you're doing. If the sample is good, you can ask them to ejaculate and collect the second sample. There are studies which compare even this and then show that obviously it's better when you collect the second sample in this, because what you are reducing over there is the transit time in the epididymis and the DFI damage which happens over there. You are reducing that damage over there. So this can be done. And all your, I don't want to sound controversial, but again, if you are having a high DFI with age, obviously things like Microfluidics and MAX can be done. You can't change the female partner age obviously over there just for the sake of it. So that's a no-go for this one. And antioxidants, yes, definitely they play a role over there. Antioxidants and your RFSS therapy and your antioxidants, what they have shown, though they might not be a quantitative change which you see in terms of your damage also, there's a qualitative change which is happening over there. So the qualitative change can be definitely seen in the studies over there. So yes, each one has its role to play. How much of a role to play, that is yet to be seen. That is the question to be answered.
There is one question. Yeah. One question: how much effective treatment with RFSH therapy is? Is it giving good results all over?
RFSS therapy, like I said, tried in very, very few patients. When you run out of options, it's quite costly. Patient has to take for at least a 1 sperm cycle, and they say 1 to 2 sperm cycles. So that's 3 to 6 months. And you're saying alternative of recombinant FSH 2 to 3 times a week. If you give, that's quite painful, quite a long one as well. But yes, there are studies which are showing that it does help. And it's not only in DFI it's going to help. There are papers which say that where you have not found a sperm in non-obstructive aerosospermia, NOA cases. There are papers from Japan as well. People who actually are at the leading front of research in for these papers, they have shown that RFSS therapy increases your sperm retrieval rates post a failed TESA in terms of your micro-TESA retrieval rates. They do increase that. So like I said, still it's open over there. I can see Dr. Sanket is raising his hand.
That is the next question. So, Sanket, please ask.
Yeah, sir, with your permission. So, yeah, Dr. Akash, thanks for that excellent lecture. So one of your slides you mentioned about the predictive factors, right? Where you mentioned about the strand break with respect to introns or exon regions. So I think why it is going to manifest in the very first generation is because it is directly going to affect the protein, right? If it is in the exon region, which is the coding part of the DNA. So, but if you look at it, intron is a non-coding DNA. But if you look at the beauty, it is very much involved in the maintaining the integrity of the coding part, right? So yeah. So well, my question is not with that. So I thought it was very excellent point. So my question is like. For giving the nutshell on the DNA fragmentation, if you look at it, still the data, even though with the plethora of data, much of the results are inconclusive. So I just want your point of view, one statement thing, where you want to treat the male or you want to treat the sperm with respect to DNA fragmentation index.
With respect to DNA fragmentation index, right now the evidence says that treating the male antioxidants is the good one. But I would obviously not see when you treat as a whole entity. I being from the medical background as well, I would like to treat the male. Try to go to the root cause of it. Try to eliminate what is causing it in the first place. Once I treat the male, I don't need to treat the sperm separately at all.
No, again, the sub question will be like that is not possible with all the cases, right? Where treating the male would be harder in all the scenarios, right? So how do you come to the?
I would say rather it would be easier. I would say rather it would be easier to treat
even in case of even in case of oats, severe oats.
Yes, see severe oats. What we are not worried about we are worried about how it plays out for the individual sperm and how it translates for the entire sperm fraction as such. We are not much worried about the individual sperm. There might be 10 of the sperms which are damaged, but I would be more interested that 10 of the sperms which are not damaged and finding that. For that, I have to obviously treat the whole thing. I can't select one sperm and treat. So obviously, that's why I said I would treat the whole male.
Yeah, the tricky part here, because the tricky part here is whichever the sperm you're going to stain or dye, you won't be using the sperm, right? So I think it's always better to treat the male.
Yes, that's
then go for the next option left out.
Definitely.
Yeah.
So there is one last question. Would you recommend TISA in case of high DFI?
We have done few cases where we had done for high DFI cases, and patient nowadays Google themselves so much, and we have a majority of our population is there who have or Google patients or Google doctors rather, and they come up with saying, "Sir, we have high DFI. You are not doing anything for it." I'm like, this is a first cycle. You don't need to. Whatever evidence is there, that is inconclusive. But the problem is we can't tell them that it's inconclusive. It will be much more difficult for them to understand. So we, as such, we are not following TISA for high DFI straight away. If the person has failed first time and the DFI value comes out to be much high on the higher side beyond the 30% cutoff, yes, definitely we would like to keep TISA as an option. But once again, TISA as a first choice, no. Because the studies are going both ways, plus and minus. It's an invasive procedure at the end of the day. And the results, what we have seen, are not as promising as what some of the earlier studies have shown it to be. And there was some papers, and last of our there, we had Dr. Alexia. I asked the same question for her, and she's like, no, don't go for TISA straight away. Use it as a last resort, probably some patient whom you want to do. And I always advise them, if you're going in for TISA, I would still like to do a split one. Nature has designed it that way. And there's some, I probably have not mentioned in my presentation over here, but your DFI in non-obstructive azoospermia, when they find out the sperm is having quite high DFI compared to your natural controls. Might be the process is getting compromised over there, that we don't know, but it's quite high. They found consistently very high DFI over there.
But there is a lot of data where they say the DNA fragmentation index or levels in the ejaculated spermatozoa is is more when compared to the epididymal sperm, right?
That we can reduce by repeated ejaculations and your therapy to a certain extent. At the end of the day, you want to mimic the nature as far as possible. You don't want to go against it. There's a common misconception that by doing IVF, we are going against the nature. We are not going against the nature. We are just trying to avoid the obstacles which are over there. And you can say in a way bypass it, but not against it. At the end of the day, whatever we do in the lab, we are trying as far as possible to mimic what is there in the nature. So how much of a DFI has a role to play naturally, we don't know. And nature has for some reason made that maturation should take place in the epididymis and it has to be ejaculated out. So that is what happens with your 85% of the population and they conceive naturally. So any given day, I would still consider ejaculate to be the first choice, except yes, in certain cases where they fail repeatedly, in that population, yes, TISA would be a choice.
Thank you, Akash. I think question will continuously coming, so we have to move ahead. Over to Yoshita.
Thank you, Dr. Sandeep.
Thank you, Dr. Akash. Thank you, Dr. Ved. Now I welcome Dr. Sanjay Shukla sir for moderate our next lecture. Welcome, sir.
Thank you, Yoshita.
Next, दिखा दो CV.
I think I
speaker
have already been introduced, so we must introduce the next speaker.
Mr. Suman, can you change the slide, please? Yeah. Yes, sir.
So it's been very fine start for the session. Congratulations, Akash. You have done a splendid job. Now I welcome our next speaker, Akanksha, who is a lab manager in Nova Fertility Center at West Delhi. She has done MSc in clinical embryology and pre-implantation genetics. She is also certified embryo biopsy embryologist by iGenomics. She has research experience, especially on frozen embryo transfer in PCOS versus non-PCOS patients. And other area of interests are ICSI and trophectoderm biopsy. So I welcome once again our next young speaker, Akanksha, and hope that she would analyze the impact that we can have from this DNA fragmentation on the embryogenesis.
Mr. Suman, you have to make her host actually. She is in participant.
I would also like to welcome in the panel Madam Firuza Parikh.
See here?
Yes.
Yeah. Mr. Suman, please make them host Dr. Firuza Parikh and Akanksha. Suman, are you there? Or Chitrakala?
Back office, please.
I think, sir, Akanksha is not.
No, Akanksha is in, you know, that she is in participant.
Sir, promoted to panelist, sir. But she needs to accept my request. Yeah. Yes, sir. Done.
Please also promote Dr. Firuza Parikh.
Dr. Firuza Parikh also.
Akanksha, can you put
she
your...
is here now.
Yeah, good. So welcome. And it's
Thank you, sir.
all
Thank you
yours.
for the introduction.
You're not audible.
How do I share the screen, sir? I'm not able to do that. Yeah.
Ma'am, please click the share screen icon, ma'am, in the bottom.
Yes.
Then please click the share icon, ma'am. Blue color share in the rightmost bottom.
It is in green actually.
Are you able to share it now?
No. You have to select. First
you have to select share screen.
And whole screen you have to select.
Entire screen, right?
Yes, ma'am.
Yeah, now it
Yes.
is coming. Yes. Now you can open that slide.
Yes, ma'am. Your screen is seen, ma'am, now.
Alright. So good evening, everyone. I will be presenting on the topic impact of sperm DNA fragmentation on embryogenesis and pregnancy outcomes. Introduction. The driving purpose of sperm is a single task to carry genetic material from one biological parent and combine with the genetic material contained within the egg of the other, creating a unique genetic code for the offspring. Think about the structure of sperm. The majority of the real estate is dedicated to its head, where the chromosomes are coiled tightly within the nucleus. The function of the neck and tail are to allow the sperm to transport its precious cargo in most efficiently. The reproductive potential of sperm is conditioned not only by its morphologically normal structure, but also sperm chromatin lesions, to which belongs, among others, DNA fragmentation. So now we know why semen analysis is not enough. As discussed in the previous presentation, a high level of DNA fragmentation in sperm may represent a cause of male infertility, and the literature suggests that sperm DNA fragmentation produces relevant impact on male infertility. Hence, it is very important to have intact chromatin and genetic integrity to achieve viable pregnancy and normal embryo development. So we will be discussing multiple studies here. The first one is by Lingen et al. 2020. This retrospective study analyzed a total of 2067 oocyte prisms, 1139 transfer cycles from conventional XP, and segregated them in groups according to sperm BFI as less than 15, 15 to 30, and more than 30% groups. The clinical outcomes were compared among these three groups. Moving on to the results, the clinical outcomes including average number of embryo transfer and frozen embryos, the rates of fertilization, biochemical pregnancy, clinical pregnancy, miscarriage, and ongoing pregnancy were not significant difference among the three groups. This study found that sperm DFI did not adversely affect the rate of fertilization, clinical pregnancy, or ongoing pregnancy in the cycle, as shown in the table. The increased sperm DFI was associated with unexplained recurrent pregnancy loss. The miscarriage rate was not significantly differed among different sperm DFI groups. The next study is by Hongai et al. 2019. This was a retrospective study of 2622 ART cycles, of which 1221 were IVF cycles and 216 were XP cycles. The rate of pregnancy, early abortion, oocyte fertilization, and good quality embryo from IVF and XP were compared between the group of low, medium, and high DFI. Additionally, the relationship between sperm DFI and male lifestyle variables such as age, BMI, smoking, and alcohol consumption, as well as routine semen parameters, were also analyzed. As shown in the table, by analyzing 1185 IUI cycles, the association between group of sperm DFI values and pregnancy outcomes were analyzed. There were no difference in general health between patients with high, medium, or low DFI, but semen parameters such as concentration and motility differed significantly between the three groups. With regard to pregnancy outcomes, the clinical pregnancy rate among the high, medium, and low groups were 12.5, 14.3, and 13.4 respectively. The early abortion rate differed significantly between the groups. Pairwise comparison of the early abortion rate showed statistically significant difference between high and low DFI groups and between the medium and low DFI groups. So analysis of IVF and XP cycles showed that the rate of clinical pregnancy and early abortion did not differ significantly among the three DFI groups. The rate of third and good quality embryos also did not differ significantly among the DFI groups. So this figure represents a correlation between sperm DFI and semen routine parameters. According to WHO manual, 15, 32, and 4 were the reference values for normal sperm concentration, motility, and morphology. In conclusion, sperm DFI is negatively correlated with sperm density, viability, and normal sperm morphology. Though it is positively correlated with age, abstinence time, and DFI does not affect the clinical pregnancy rate following IUI, it may have increased risk of early abortions. Pregnancy outcomes following IVF and XP are not related to sperm DFI, and elevated sperm DFI does not impact oocyte fertilization and embryo development. The next study is by Zhang et al. 2018. Sperm DNA damage was assessed by STD test. and the semen and motile sperm harvested by combined density gradient and SIMA in 161 couples undergoing IVF. Semen analysis and sperm DNA damage results were compared between couples who did and did not achieve pregnancy. The sperm DNA damage level was significantly different between the two groups and was negatively correlated with IVF outcomes. To examine the relationship between sperm DNA damage and early embryo development, they analyzed the level of sperm DNA damage and embryonic development after IVF. Descriptive analysis of data for couples receiving IVF is listed in the table. The cycles were divided into 3 groups according to the level of DNA damage of motile sperm, and they did not identify any statistically significant difference in the 3 groups with regard to female or male age, FSH level, female BMI, number of M2 size, birth rate, but the day 3 good quality embryo formation, blast formation, and implantation rate and clinical pregnancy rate in the group with sperm DNA damage more than or equal to 21% were significantly lower than in the group with less than or equal to 10% and 11 to 20% damage. There was a tendency for an increased spontaneous abortion rate in the 3 groups with increasing level of DNA damage, although no statistical significant difference could be detected. So this study is by Tai Chang 2018 study. This was a prospective study. A total of 390 couples underwent sperm fragmentation prior to receiving conventional IVF or XP were evaluated. The test that was used for the evaluation of DNA fragmentation was the sperm chromatin dispersion test. According to the results, in the IVF and XC group, when BFI threshold had a cutoff value of 30%, there was no significant negative correlation between BFI and birth rate, good embryo quality and pregnancy rate as shown in the table. In the XC group, birth rate and embryo quality rates are not significant. There was no difference in pregnancy rate, although there was a decreasing trend in 30% BFI subgroup. The results from this study confirmed that BFI was not related to birth rate, good embryo rate, or pregnancy rate. The next study is by Fedor et al. 2017 study. 82 externation and pregnancy rates were assessed. The patients were divided into 2 groups with tunnel test less than 15% and more than or equal to 15% BFI value. Moving on to the clinical outcomes, ICSI results in terms of birth, blast, and pregnancy rates are shown here. The same data is shown in the lower table for sperm sample with high and low level of DNA fragmentation. The results reveal that the existence of negative correlation between DNA fragmentation and blastination rate exists, and an association between high level of DNA fragmentation and low blastination and pregnancy rate per transfer. The next study is by Hong 2011. The aim of the study was to investigate whether sperm chromatin dispersion assay results after synapse are related to fertilization, embryo quality, and pregnancy rate following IVF. A total of 223 couples undergoing IVF were included in this study. The patients were divided into 2 groups, tunnel less than 15% and more than or equal to 15% DNA fragmentation. As shown here, no statistically significant difference in the IVF outcome regarding number of insights received, birth rate, viable embryo rate, clinical pregnancy rate, and abortion rate were observed between the 2 DFI groups and the 2 HDS, that is high DNA sustainability group. One difference noted between the 2 DFI group was that good embryo rate in DFI less than or equal to 27% group was significantly higher than in the DFI more than 27% group. The next study is by Men et al. 2022. It was a prospective descriptive cohort study that retrieved data from 162 couples who underwent 3 cycles. General characteristics, semen parameters, sperm DNA fragmentation index, fertilization, embryo development, pregnancy rate, and early pregnancy loss were assessed. So the results, here the table shows embryo quality and pregnancy outcomes according to the DFI. Statistically significant difference in the DFI was observed only for the clinical miscarriage subgroup. Although not significantly different, the DFI value was higher for the subgroup with a low birth rate, low number of feasible embryos, and with early pregnancy loss. Embryo development could be delayed. Poor quality was found in the group with high DFI. ICSI result with DFI more than or equal to 30% indicated a statistically significant decrease in first grade normal cleavage rate and top grade embryo rate on day 3 compared to those with low DFI. In this study, a cutoff value of more than or equal to 16.6% based on RSC method to predict an increased risk of early pregnancy loss when analyzing embryogenesis. Using this threshold showed no significant difference in first grade normal cleavage rate and top grade embryo rate on day 3. So this is a systematic review by Adija et al. 2021. So this actually reviewed databases till 2020. Total of 10 studies were included in the meta-analysis. Of those, 5 were prospective and remaining 5 were retrospective studies. The main outcome of interest was to compare blast rate in two groups, that is high DFI and low DFI group, based on the percentage of sperm DNA damage expressed as DFI. The other outcome of interest was to compare blast rate in high DFI and low DFI sperm DNA fragmentation group based on different sperm DNA fragmentation assays, which were Comet, SPD, FPF, and Tunnel, and different type of ART treatments, which were IVF, XC, or combined IVF plus XC. According to this meta-analysis, there is an overall non-significant increase in blast formation rate in the high sperm DNA fragmentation group in comparison to low DFI group. Subgroup analysis in different type of sperm DNA assay used to evaluate sperm DNA damage and in different type of ART procedures. So it was found that similar positive trend in the high DFI group with SPD and tunnel assay, but the blastulation rate was better in the low DFI group with SPD assay. So a slight positive effect on blastulation rate in the high DFI group when IVF was used as a method of ART, and there was no difference in blast rate between high and low DFI group and XC or mixed IVF plus XC is used as a method of ART. And this is the last systematic review by H. Newman et al. 2021. This included 36 articles that examined a specific repair mechanism utilized by the oocyte and embryos for DNA repair of sperm DNA damage. So it was observed that zygote that fertilized by genotoxic stress spermatozoa had increased amount of increased amount of chromosome and chromatin type of abnormality, and that these genetic lesions could be repaired by fertilized oocyte. The figure here shows global expression of mRNA transcript and DNA repair activity in mouse and human embryos. The global expression of mRNA transcript in the metaphase 2 are in abundance and of methanolization. So these transcripts decrease with advancing embryo development, and at embryonic genome activation, the embryo starts to produce its own mRNA transcript, and these increase with future development. The zygote relies on stored maternal mRNA and proteins to repair DNA damage. Therefore, over or underexpression or mutation of these genes potentially compromise embryonic development. Cell cycle, oocyte and embryonic stage, age and fertilization by DNA damage are some of the factors that influence mRNA expression in the oocyte and early embryos. Reactive oxygen species are required for activation, capacitation, and acrosome reaction, which is known. However, an excess of ROS production can induce unwanted oxidative stress. So, zygote fertilized with oxidatively stressed sperm retain higher amount of DNA methylation, suggesting that mechanism of DNA methylation in paternal pronuclei is impaired. So, the impact of active DNA methylation may influence the expression of development critical genes, as developmental errors were observed in this study in zygote stage. So, as shown in the table, sperm DNA damage results in cleavage delay in the embryos. Out of the 17 studies describing cleavage delay, one found no change when fertilizing the sperm harboring DNA damage. 10 studies observed a delay in first cleavage, while 2 observed a delay at day 2.5. One study found that delay beginning from day 3, 3.5 or 4. Claims of delay beginning at 3, 3.5 and 4 had one supporting study each. The figure here represents a summary of biological consequences in embryos derived from damaged sperm. When a sperm harboring DNA damage fertilizes an oocyte, there is no change in the fertilization rate compared with undamaged sperm. There is a delay in cleavage rate starting from first cleavage regarding further development compared to the embryo fertilized with undamaged sperm. So there is a decreased blastocyst formation, implantation, and live birth in those fertilized with damaged sperm. To summarize this, measuring sperm DNA damage could be a promising tool in determining a man's fertility status. However, the relationship between this measure and the ART outcomes remain uncertain. DNA damage in sperm and its impact on embryogenesis pregnancy outcome following ART is inconclusive in the literature, and also the evidence for this is insufficient. So there are large discrepancies between the published studies regarding the impact of sperm DNA fragmentation on embryo quality and pregnancy outcome. Some researchers have found that there is a negative correlation between the two, but however, the others found no association between them. So there could be multiple reasons for these variations in results. One reason for the inconsistent literature is the variety of methods used to detect sperm DNA fragmentation in different studies. It is inevitable that the different mechanism underlying these methods may result in discrepancy. Even with the same detection method, the use of varying thresholds and inconsistencies in lab practices can also lead to studies drawing different conclusions. Another possible cause for discrepancy is the small sample size of most previous analysis, which could result in error. The potential adverse effect of sperm DNA damage on the quality of post-implantation embryo and spontaneous abortion should be a matter of concern. Embryo development depends in part on the inherent integrity of sperm DNA, and that there is a threshold of sperm DNA damage between which fertilization and embryo development are impaired. So oocytes are believed to have an inherent ability to repair the effect of fertilizing from the damage. However, the oocyte loses its ability to repair with increasing maternal age, poor DNA results, and poor quality of oocyte retrieval. The oocyte seems to have a threshold beyond which DNA sperm damage appears unrepairable and may negatively impact embryos. So it was traditionally accepted that the male genome becomes activated at the later developmental stages of embryogenesis. Interestingly, high sperm DNA fragmentation levels could influence early embryo development up to 4-side stage, in which the paternal genome is thought to be inactive. Sperm DNA fragmentation may activate additional DNA repair pathways, and the embryo development could be delayed, resulting in poor quality embryo. An understanding of the molecular mechanism of the repair capacity of oocytes and embryo is missing. So, further investigation towards future into these mechanisms will aid the eventual and important development of therapeutics to improve fertility in advanced reproductive age. The pregnancy and miscarriage rate in ARD are dependent and confounded by other female factors like elevated progesterone on the day of trigger, fresh or frozen embryo transfer, not just limited to high sperm DNA fragmentation. Interventions such as 50-50 and testicular sperm extraction can improve the live birth rate for patients with high sperm DNA fragmentation. Since testicular sperm extraction is an invasive method, it is generally recommended that the testicular spermatozoa are an alternative for patients with high sperm DNA who have failed recurrent IVF cycles or other less invasive interventions. The future prospective studies with large sample size are required to confirm the existing findings. Thank you.
Thank you, Akanksha. You have described the effect of DNA fragmentation on embryogenesis in very concise way. I have very simple questions to you. One is, you have mentioned a lot of published studies, but I would like to know about your experiences. Like, do you do DNA fragmentation tests in your laboratory? What is your observation with the different levels of DNA fragmentation and different stages of embryogenesis in your laboratory?
So we do perform sperm DNA fragmentation only in the indicated cases, and we do it by sperm chromatin dispersion test. I believe there is a negative association between the high sperm DNA fragmentation and the ART outcome, because we don't sometimes get embryos in the patient where the factor is totally unknown, and we then suggest them to go for a DNA sperm fragmentation test. And many times this has happened with me that we have got high sperm DNA fragmentation in those patients.
Okay, so do you have any preference on the type of DNA test that you get it done?
Yes, so we perform DNA fragmentation test by sperm chromatin dispersion.
SCD.
Yes,
But do you have any options?
no, the options are not available with us here. I think it is handy and it's user friendly, so we use it for all of our patients.
All right, and have you done the DNA fragmentation tests yourself?
Yes, yes, I have done it.
Do you observe any interperson variations in the DNA fragmentation index when?
Yes, so we have a protocol of counting 300 sperms, and it should be done by at least 3 people in the lab. So we actually take out the average and then finally give the percentage of fragmented spermatozoa to the patient.
Okay, so another question related to this, because at a time, I believe only one person is preparing the slides.
Yes.
Doing the whole thing. It's only the 3 persons who are reading the results. So this could be the interperson variability. But if the person who is doing the test, can someone induce DNA fragmentation while doing the test?
I'm not sure. I think, if 3 people are checking it, it is very less likely that one person can induce, sperm DNA fragmentation.
No, I'm not asking about the readers. I'm asking about the person who's performing the test.
As in the procedure, the steps which are involved in the test?
Yes.
Yes. Yes, I think that is one thing, because with SCD, we sometimes don't get the halos properly if the staining is not done properly. So I think that could be one of the reasons how we can induce. And if the person has not seen it, if the person is new in the lab and they have not seen many sides of DNA fragmentation, then they might think that for this particular patient the fragmentation level is high, but there won't be any halos. Actually, it was a test. It would be the procedural error.
So do we have any validation of the test that we are doing?
So it's just that we take the kit from a validated source and we perform it as per the protocol. So, and nothing else.
Sanket, some say this. Yes.
Yes, sir. Sir, to just elaborate your answer to the question what Akanksha has mentioned. Yes, I think the inducer might be the person who's preparing the slides also, because if you expose to the temperature which is beyond the optimal the level, I think you're inducing the fragmentation, the exogenous DNA fragmentation as well. That is first point. Second point will be if you're subjecting it to centrifugation prior to your preparation of the slides. I think again you're inducing, if the RPM or the recommended levels are greater than that, I think again you're inducing it at another level. So I think yes, the inducer would be the person who is going to prepare as well if the recommendations are not followed. So my question to I have one question to Akanksha. So with your permission, sir. So
yes,
yes. So Akanksha, one of your earlier slides, I think you mentioned about the paper where you quoted there is no difference with respect to DNA fragmentation and rate of fertilization and as well as rate of blast deletion also rate of, clinical pregnancy outcomes. So what do you think? Do you think it is, I think it is unfair statement where, because the sample size, the study population, what they included is not clear, whether they included only the normospermic samples or even the oat samples as well. So with that note, how do you defend this?
I think I have mentioned so many studies, and different studies showed different results. There were many studies that I came across which showed no statistically significant difference between high sperm DNA fragmentation and the ART outcome. Nothing at all, except for probable miscarriage. It was common for almost all the studies.
No.
No.
You mentioned some studies also, which is not concerned about the final endpoint, where you showed some study on the Rattus novagicus model, mice model, where you mentioned about there was a delay in the fertilization as well as the blastulation formation. So I think it is affecting, right? It is not only affecting the endpoint, but at least it is affecting the pre-implantation development stage, right?
Yes. So that's what I'm saying. That different studies reveal different results. I have added two meta-analysis. So one, the bigger one, it actually showed the results that you are saying, the mice study and everything. The earlier one, which was the Indian study by I think Prashant Adiga, 2021 study, that actually revealed no significance at all in all the days. So there are different studies. However, if I talk about my experience, I feel there is a negative effect on the ART outcomes with increased sperm DNA fragmentation. This is as per my experience.
Great. So congratulations, you're done.
Dr. Hetal Shukla want to say something.
Yeah, please.
Hanji, Dr. Hetal, please unmute yourself.
You're not audible. Now.
You are not audible.
I think your system needs to be checked.
Yeah.
Now.
Dr. Hetal, you just log out and again log in. That will help you. I think we can move ahead, sir.
So
thank you, Akansha. Thank you so much. It was excellent lecture. We can move ahead.
Thank you, Dr. Shukla, sir, and thank you, Akansha. Now let's move for further sessions. I welcome Dr. Nancy Sharma.
So we have already discussed about how sperm DNA fragmentation affects male and female. Now moving towards the next section, where we will be discussing about the various tests which are available for sperm DNA fragmentation. For this, I would like to call Dr. Sanket Dhumul for moderating this session. Dr. Sanket Dhumul is a senior clinical embryologist at Keshma IVF Fertility and Reproductive Center, Bangalore. Sir is an ASHRAE certified clinical embryologist. He is an executive committee member of ACE and scientific committee member of NIDA. He is also an editorial board of journal JBRA Assisted Reproduction. He is a reviewer of journals like JBRA Reproduction, +1, JRHM, and OGS. He authored few publications to his credits, and he is principal investigator for several projects at Keshma Medical College. Sir is member of ACE, ASHRAE, and Indian Science Congress. He's a regular faculty in various national and international conferences.
Thank you so much, Nancy, for that kind introduction. So, taking the session forward, I would like to introduce the next speaker. So we have Dr. Hetal Shukla with us. So he's a laboratory officer from October 1996 to January 2009, and he has done something on production of frozen semen for artificial insemination and embryo transfer technology and IVF for OPU in cattle and buffalo. And he has been reproduction biologist since 2009 to 2015. He worked at multiplication of Arabian Thar, endangered national animal of UAE, using ART including somatic cell nuclear transfer. And also he's been chief embryologist from 9th July 2015 onwards, where he has been managing multiple embryology labs, structure, and also has been part of structured training of new androtechs, IUI workshops, and as well as in-house workshops to train, update or the androtechs. So without much further delay, I would like to hand it over to Dr. Shukla.
Just a minute, I will share. I'll share my window.
Sure, sir.
Is my screen visible?
Not
No,
yet.
sir.
Just, in this session,
Yes, yeah.
male infertility usually, yeah.
So, sir, sorry
Okay.
to interrupt. I think please go to slideshow more, so that it will be better for the audience to view the slides.
Let me see. It is in this slideshow.
Sir, please stop. Yes, sir. Please stop here and share 1 second, sir.
Just a minute. Is it okay now? I think.
Your sites are visible, sir, but not in the full screen mode.
I don't know why it is happening.
Sir, I will help you out, sir. So please click the share screen and click on the screen, full screen and share, sir.
Okay.
Please stop share, sir.
Just a minute. Now it should be.
Dr. Hetal, you can see the last option that where it is written as 59%. Next to that, you can see a small icon, right? Please click on that.
No, I can
sir,
see
that's
on
what,
my screen.
That's what,
Okay.
sir. Sir, you want to like stop share? Please stop share. Click the share screen, sir, and click on the screen. Don't click the PPT, sir. Click on the screen icon. Screen icon.
That's what.
Screen icon, sir. In the top first one.
Share entire screen.
Yes, entire screen and then share.
Okay. I don't know. Something is wrong. Hope it is okay now.
Yes, yes, perfect. Please go ahead.
I'm sorry for this delay. Anyway, uh, normally semen analysis is carried out in most of the laboratory based on the WHO recommendations, but which is very limited to the basic sperm parameters. Detailed semen, which does not say uh, anything about the perfectly anything about sperm fertilizing ability. So before we move on to the DNA fragmentation, there are certain paternal contribution to the fertilization and to the development of healthy offsprings, which are reported in various publications, which is summarized here. Increased risk of schizophrenia or autism in offspring from fathers with increasing age, and increased risk of cancer also in offspring from fathers with increased level of sperm DNA fragmentation because of smoking. Many various genetic diseases, epilepsy, some birth defects are also linked to the paternal contribution, and there is an association between increased SDF sperm DNA fragmentation and subfertility also. So abnormal chromatin packaging is more recurrent in men with normozoospermia undergoing ART treatment in fertile men. So high sperm DNA fragmentation and prolonged time to pregnancy, all these factors are contributed by paternal contribution, and that is how this directly leads us to a question: why this sperm DNA fragmentation testing is not a very important tool to treat the male fertility patient. DNA, what DNA is, everyone knows, but the DNA of somatic cell and a sperm has a very little, one big difference. Somatic cell DNA is draped around histone with histone proteins, whereas in sperm, DNA histones are replaced by protamines, ensuring proper condensation and preventing from sperm DNA, which undergoes transcription and translations. Protamines allow the DNA to be at least 6 times more condensed than in chromosomes, and male genome is protected against major insults it faces, and which ultimately occurs in a DNA damage. So, histone replacement failure by protamines during chromatin compaction may result in poor quality of chromatin package and DNA damage. So DFI, which is DNA fragmentation index, this can be either testicular or post-testicular event, which in earlier lecture also by Dr. Akash Agrawal explained very well in detail. So maybe in testicular event, DNA can happen maybe due to protamine deficiency, oxidative stress, unrepaired DNA breaks, and abortive apoptosis. So as a post-testicular event, unfavorable epididymal environment, endogenous endonucleases, and excess of estrogens, or caspase activation, which plays role in apoptosis, necrosis, and inflammation, exogenous gonadotoxic agents, the reactive oxygen species, and so on. So many factors affects, and it can be. So DNA fragmentation index is an effective method measuring sperms with fragmented DNA in an ejaculate. It is represented in a percentage, and overall, if we look, the values of fragmentation index, it we can classify excellent to good if it is below 15%, good to fair DNA integrity if it is between 15 and 25%, fair to poor 25 to 50, and more than 50, it is always believed to be very poor DNA integrity. So DFI, lot many things are said about impact, and mainly it gives impact in three areas: infertility, impaired ART outcome, risk of genetic birth defects. DFI tests, yes, of course, so many, basically the 8 tests which I have listed, we will discuss in details. Treatment, yes, antioxidant, antibiotics, or abstinence, frequent ejaculation, lifestyle modification, uh, advanced sperm selection methods, and testicular sperms are the options. Why should we carry out? Yes, we have gone through in our previous lecture also so many impact on embryogenesis, genetic integrity of sperm, causes the normal embryo development. So routine semen analysis cannot detect high level of sperm DNA fragmentation. Elevated levels of above the critical threshold will compromise successful pregnancy. High SDF does not appear to affect fertilization or the first or second embryo cleavage stage. High SDF can affect embryo cleavage once the paternal genome is switched on and subsequent blastocyst development. DFI levels are closely correlated with IUI, IVF, and ICSI miscarriage and pregnancy rates, that is significantly higher in subfertile men. Men with poor semen parameters are more likely to have high DNA fragmentation and may have another this Henkel and Daniel Franken have published that in the cases where the oocyte of or the embryo does not counter these damages to the male genome in terms of repair, an elderly abortion, sperm DNA damage, fragmentation can cause childhood cancer as well. So various scientists have given their observations or findings on DNA fragmentation. So man's age with more than 40 years at the which may put him at the high risk of SDF. Increased diploidy or aneuploidy rates in spermatozoa of aged men. Smoking induces sperm DNA damage. Smoking activates checkpoint kinase, facilitates S and G2 checkpoint arrest, and etc. Alcohol consumption also triggers SDF. Alcohol consumption leads to the increased release of hydrogen peroxide from sperm mitochondria, resulting in sperm DNA fragmentation. So increased risk of sperm DNA damage and lower sperm motility. Obesity induced oxidative stress has a negative impact on sperm DNA integrity. Exposure to endocrine disruptions, chemical positively correlates with SDF. Bisphenol and exposure leads to high SDF, and so on. In chlamydia and mycoplasma infection, SDF is very high. Patients with leukocytospermia also exhibit high level of sperm DNA damage. Varicocele is also associated with high SDF. So indication and causes, definitely lot many things are said. So just I have listed. Major cause of sperm DNA damage is oxidative stress, abnormalities in regulation of apoptosis, or defects in topoisomerase. One interesting paper I found was hypoosmotic swelling test, which identifies individual spermatozoa with minimal DNA fragmentation. So here in the picture, you are seeing different patterns of hypoosmotic swelling, coiled patterns of the spermatozoa. So these are graded from A to G, A, B, C, D, E, and F, G. So it was concluded that pattern D, E, and F is showing very positive correlation. I mean, very it is so sperms with a very good DNA integrity. They are proven, and this HOS test this way can be used to predict the DFI, and confirmative test can be carried out by SCD, SCA, SA, tunnel or comet, anything. So HOS test can also be used to select the spermatozoa for ICSI-IMSI with least DNA fragmentation and with intact membrane. As we are going to overview the old and the new of the tests, here is the timeline starting in 40s, 50s, 60s, 70s, and 80s, 90s, and all. So 1953, determination of the double helix was there. In 1963, chromatin structure of suturing was found. 1970, acridine orange denaturing of bull sperm was carried out. 75, lower fragmentation in trout sperm than somatic cells. 1980, SCSA was developed, and in 1980, Comet was developed. 1990, tunnel was used first time in the human spermatozoa. 1996, SCSA, sperm chromatin structure assay in human spermatozoa, and so on. So till that, you can see this timeline. HA binding in 2010, MAX was introduced in 2007, but the most important, which is very commonly carried out in most of the laboratory, SCD test, I think was introduced in 2005. So in 1940, is a unique complex histone X was discovered in the 50s and 60s. Association between unstable chromatin structure and subfertility was investigated. In the 70s, the impact of induced DNA damage was investigated. 80s, the concept of sperm DNA fragmentation as related to the infertility was introduced, as well as the first DNA fragmentation test, that was SCSA, was carried out. The tunnel, followed by others, was introduced in 1990s. Now, in present times, within the research area on SDF, all the recent methods are submerging and sorting of the cells with increased DNA fragmentation, and hyaluronic acid binding techniques are also prevalent now. The clinical value of this test remains to be elucidated. In spite of half a century of research within the area, this analysis is not routinely implemented into the fertility clinics. The underlying causes are multiple. The abundance of methods has impeded the need for a clinical significant thresholds. The sperm DNA fragmentation and predictive value, of course, 26%, 26.1% with when you are carrying out the sperm chromatin dispersion test, it differentiates infertile and fertile men. In tunnel assay, 25.5% of the cutoff distinguishes between successful and failed IVF or ICSI outcome. In sperm chromatin structure assay, 30% cutoff also establishes an association with ART outcome. Several studies meta-analysis shows no or only poor predictive value for ART outcome. And many studies have indicated a medium to good predictive power when the tunnel, SCD, Comet, SCSA were performed. So, no consensus. Some controversies are there. In 2017, Dr. Agrawal and all have published sperm preparation by DGC doesn't affect DNA integrity. SDF testing in knit semen gives good result with regard to ART outcomes and high SDF before DGC predicts impaired SDF, but after semen processing and SDF testing, after DGC does not provide additional predictive power. In infertile men with high grade varicocele and normal semen parameters, or low grade varicocele with abnormal semen parameters, a varicocele repair may be considered. Several studies have shown that higher SDF can also be seen in men with varicocele despite having normal conventional semen parameters. Varicocelectomy, a significant decrease in SDF as well as improvement in the total antioxidant capacity has been also reported. So these are the available tests which are generally divided in two groups: tests which measures DNA damage and test which measures chromatin condensation. Tests measuring DNA damage are again classified in two parts: test measuring direct DNA damage, whereas other one is test measuring potential of DNA damage, that is the secondary sign. Test measuring DNA damage is 8-oxy 2-deoxyhydro guanosine testing, tunnel assay, comet assay under neutral pH condition, and measuring potential are SCSA, SCD, comet assay under alkaline pH condition. It is important to differentiate direct DNA damage, and DNA strand breakage, and also abasic sites, base modification, DNA, because these also have their significance in the outcome. So, and tests which measures chromatin condensations are aniline blue, toluidine blue, and chromomycin A3. But no test means we can say SDF test failed to detect exact nature and location of SDF. So different tests available and their principal advantage and disadvantages are listed here. Like internal advantage is sensitive, and although we are going to look at all these tests individually, and we will try to understand in detail. So about the, I would like to talk first about tunnel assay. Tunnel assay is believed to be the gold standard among all the tests, because single and double stranded DNA breaks are both labeled with fluorescein thiocyanate in a single step staining method before the sample undergoes fluorescence microscopy or flow cytometric analysis. In the tunnel assay, a template independent DNA polymerase, the terminal deoxynucleotidal transferase, adds the FITC-DUTP label to the nicks at the 3-hydroxyl end of the DNA. Now, thus, if there are more nicks in the DNA, more FITC-DUTP will be bound, resulting in more cells fluorescing with a stronger fluorescent signal, which is then observed in a fluorescent microscope or measured by the flow cytometry, and we can see tunnel positive and tunnel negative cells like these. Sperms with fragmented DNA negatively correlates with motility, morphology, and concentration. The predictive threshold with a good to high predictive power depends on the methodology and specific protocol used, with varying threshold values of 20% to 36%. Tunnel with fluorescence microscopy is labor intensive, time consuming, and evaluated sperm number being very low, maybe 100 or 200 cells, in contrast to the 10,000 cells measured in a very short time with very high accuracy with flow cytometric method. But again, when you go for flow cytometry, it becomes expensive and cost prohibitive. Results are significantly influenced by time of incubation, type of fixation used, and the fluorochrome used to label the fragmented DNA. Thus, tunnel assay having several protocols, one need to make a choice and standardize. The another test which is becoming slowly very popular is sperm chromatin dispersion test, and very easy to perform kit based test. So halos resulting from the released DNA after denaturation are size graded under bright field microscopy or fluorescent microscopy. Unlike other tests, it measures the absence of DNA damage rather than damaged DNA in the sperm. One limitation of the assay is its low density nucleoids are relatively faint with less constrained image. Easy to perform, a good predictive power for fertilization and pregnancy after IVF and ICSI. SCD can be combined with evaluation of 8-oxoguanine levels, which is a marker of oxidative stress by using specific probes. These 8-oxoguanine levels in sperm with fragmented DNA indicates very clear association between these two types of DNA damage. So clinically, SCD is negatively correlated with pregnancy or the live birth. A meta-analysis by Sisson et al. Indicated that the SCD test has poor predictive value for positive ART outcome. This is the flow chart where agarose is melted at 90 degrees centigrade, where the person who carries out the test need to be very critical to bring that melted agarose to bring at 37 degrees centigrade. Otherwise, this may induce the DNA fragmentation in the spermatozoa going to be exposed to the agarose. Rest of the denaturation, lysis, these are very critical step where one need to be very particular about the time exposure of their solutions, and then dehydration and all are the stops. Ultimately, we can see the halo formation will be seen and it can be assessed. The third test is COMET assay, single cell gel electrophoresis. The principle of this test is permeability and electrophoretic movement of fragmented DNA. Comet appearance results from the stained, unwound DNA fragments that form a tail after electrophoretic movement in the agarose gel that gives its unique name, a comet. Unfragmented DNA remains in the comet head. It quantifies DNA damage by measurement of displacement of the nuclear genetic material, which is in the comet head, and the migrated unwound DNA tail. The tail length that is measured, and the index of it says about the index of the DNA damage. The tail moment or the torsional moment of the tail is obtained in this assay by multiplying tail length with the fraction of the total DNA in the tails when visualized using a fluorescent DNA binding dye. This is how the comet positive sperm will look like. This
Dr. Hital, I'm sorry to interrupt. You have 2 minutes left.
Yeah, sir, I will go a little fast. So
Sure.
this test, yeah. The another test is 8-OHD, which is a byproduct of oxidative damage of sperm DNA. Owing to this distinguishes between fertile and infertile man. Results have been shown to positively correlate with tunnel assay, and this is reportedly higher in smokers and infertile patients with varicocele. This test is carried out in 3 steps: DNA extraction, enzymatic digestion, and HPLC, high pressure liquid chromatography, is carried out. Acridine orange is a fluorochrome that measures the susceptibility to denaturation of sperm nuclear DNA, and positive normal DNA and DNA damage in this picture we can see. And the flow cytometric version of this acridine orange is called sperm chromatin structure assay. Of course, it is. So chromomycin A3 again is an anthraquinone glycoside produced by specific strain of bacterium in the presence of magnesium, and that binds to DNA. And this is again this CMA3 positive spermatozoa stained bright yellow or bright green indicate inadequate DNA protamination. CMA3 negative spermatozoa faint yellow or dull indicates high DNA protamination. Toluidine blue, yes, the images we can see infertile and healthy. Again, it's a basic thiazine metachromatic dye, specifically binds to acidic cellular components of the tissue. Aniline blue used to determine chromatin condensation, and seminal plasma influences the staining. Sometimes while carrying out aniline blue, one may need to wash the spermatozoa with phosphatase buffer saline. Potential predictor of IVF outcome can be this aniline blue can be used. What are the challenges? Now, last three slides are there. Challenges in sperm chromatin integrity test. There are two types of tests. Every test has its own importance. So each of the different types of DNA damage would have to be determined by the different assay. DNA strand breaks are referred as the DNA damage. The other DNA damages like abasic site base modification are also important. SDF testing method fails to detect the nature and location of. So in short, no consensus over the test, but what should be the future directions? So professional societies will need to undertake initiatives to re-review clinical practice guidelines for SDF testing in the evaluation of infertile men. In the best interest of the patient, it is essential to identify those patients who can benefit most from the SDF testing, and well-designed studies can help in this. So what are the clinical practice guidelines available in case of clinical varicocele, unexplained IUI, RPL, recurrent pregnancy loss, and IVF ICSI failure, and borderline and observable spermatozoa? So SDF testing, in which cases one can recommend? So this review has recommended these things. So take home message is sperm chromatin integrity analysis serves as predictor of fertility outcomes in both natural reproduction and ART. High SDF is a paternal derived defect causing ART failures and miscarriages. Each assay available for the evaluation of sperm chromatin integrity and SDF is having its own pros and cons. To obtain the relevant information, compare the features of the SDF test before selection of specific SDF test. Cutoff values for SDF test require validation and consensus. So these two articles has helped me. So thank you, the publishers, and thank you, iHera, and thank you all for giving me the time and opportunity and listening me patiently. Thank you.
Thank you so much, Dr. Hetal, for that elaborative lecture on nutshell on the various tests available for to assess the sperm DNA fragmentation. One interesting thing which I observed in your presentation is, like you mentioned, one of your slides, you mentioned about the utility of HOS with respect to sperm DFI. That is something quite impressive and a new thing which we are not aware of. And well, coming to the question, and see the category system, what you mentioned for DFI, you mentioned mainly 4 categories, right? So one is less than 15, and second category is greater than 15 and less than 25. And third category is more than 25 and less than 50, and fourth will be greater than 50. So if you my first question with this thing is, this index is with respect to with any particular test or is in general?
In where the indirect DNA damage like SCD in general, I mean SCD, SCSA. For this kind of test, this can be categorized.
Yeah, because the follow-up question will be, even I do SCD at my lab, and how I categorize the indexes into 3 categories rather than categorizing them to 4, where the first and second will remain the same as you mentioned, but the third will be anything greater than 30 I consider as poor to very low to poor fertility potential. But whereas in your case you mentioned another 2 extra categories where it goes above 50% as well. So in that scenarios, I think it will be very difficult for the embryologist to decide whether to go for IVF or ICSI, or to go for to treat the male first, or in case of application of sperm preparation techniques, whether to go for max or not. So I just want to know your point of view. I just wanted to know your point of view on that.
See,
So it makes
basically, the fundamental question at that point of time remains that what after the cutoff value, I mean, what after you get the result out of the test where you have carried out SDF, right? What next? And very limited options we have. We have either first option maybe IMSI. After that you can go PICSI or MAX. So ultimately, whether to treat male or the sperm, that only remains. And at the laboratory point of view, where are very few points are available. And in my opinion, probably at that point of time, when motile spermatozoa are going to be considered, maybe high hyaluronan binding can also be used to replace, whether to opt if PICSI or not. Means HbA testing also can be carried out. That's what means.
Yeah.
So in our laboratory, what we means, my experience. So what we do is, it is an established fact that yes, when there is a asthenozoospermic sample, DNA fragmentation is going to be high. Definitely, it is going to be high. And with this established fact, we go for the semen sample of DNA fragmentation index to decide what to opt for in the laboratory. And the semen sample which are going to show a good motility, say more than 25-30% and above, that point of time we will carry out hyaluronan binding assay to decide whether to go for PICSI or not, or like that, any other thing.
Thank you so much for that. And sir, I think one of your slides you mentioned you gave the statement like none of the tests are more effective in determining the decision. Because I think just to elaborate that, I think because of all of the tests which are available, I think they are based on the qualitative part, not the quantitative part, not the qualitative part. I think that makes a huge difference for the clinical application of any test that is available for the sperm DNA fragmentation. Yeah, thank you so much, Dr. Shukla, for that. And I think I just want to mention there is one interesting discussion going on in the chat box where Dr. Firuza, Madam asked apoptosis and about apoptosis in physiological phenomena. At what level does it affect? What I would like to say is I mentioned already one stage there where it begins at very early stage. I think where it is going to differentiate from the primary stem cell population. But the enzymes which are responsible for apoptosis, say the caspases which are involved, or sorry, I'm not getting the name of the proteins and genes, so which are involved in apoptosis, I think they are very much stringent that they don't allow the cells to get differentiated to the next stage where there is a major fault in that. I think Dr. Firuza, if you are there, or Dr. Akash, I think, what do you say about that?
Hello, Dr. Sindhu. I think
Ma'am is there, yeah.
She can.
A technical team, please promote Madam to panelist level now.
Sure.
Dr. Akash, please your comment on that.
Yeah.
Because that found to be a very interesting question. Yeah.
Yeah, it is really interesting because apoptosis as such marks the cells which are to be attacked by the immune system of the body, right? So they need to be absorbed back. So my point of view was slightly different in that, yes, apoptosis has a very important role to play. Ma'am has highlighted that it has a physiological role to play. It's like your gatekeeper enzyme over there, something like a gatekeeping it is doing over there.
Housekeeping enzyme.
Housekeeping enzyme, where it is housekeeping part it is doing, where it is culling out all the sperms which are defective. That is that. But if that happens early, they can be removed. But if that apoptosis sets in later, the problem would be that these would come into your ejaculate. That's when they would start to cause problems in terms of your natural conception or in terms of your ART procedure, because they can get selected. Sperms which are apoptotic but still can get selected because externally we don't see much of a difference over there in terms of the sperm morphology and other things. Not 100% correlation we see. So these apoptotic sperms are...
You mean to say at the level of spermiogenesis?
Yeah, after spermiogenesis and spermiation. So if it happens at the later stages, they are obviously it has been labeled as apoptotic because it is abnormal after spermiation. Then only they would be labeled as apoptotic. But there's not enough time for it to be absorbed back, for it to be deleted from the ejaculate. So that's when they come into the ejaculate. So these are the ones which are more, I feel, more of considered. Yes, definitely when they happen early, they are important because that's the basic function of that apoptosis, to remove the cells which are not good.
I think that is
a matter of concern when it happens later.
So I think that is why we have to move it because already it is 7 now.
So Madam is here. Madam, want to comment anything on that at last?
Sure. Can you hear me?
Yeah, ma'am, please.
Yes, ma'am.
Yeah. So it's a very, very interesting webinar. My contention was that abortive apoptosis happens at all stages of spermatogenesis, and maybe abortive apoptosis contributes to ROS, which indirectly will affect the sperm. If abortive apoptosis doesn't happen and there are no checkpoints, then this will lead to mutagenesis, and it can be mutagenic and carcinogenic. So at what point, my question, I've understood the theory. My question to you is, at what point will you say that now there is too much abortive apoptosis? Is there any parameter? Is there any level? Is there a method by which we can say the fragmentation is caused because of too much of abortive apoptosis?
Yeah, ma'am. The point is, I think it begins at very first stage of spermatogenesis, where it divides from the main stem cell population, stem cell pool population. But if you look at it, since the number is very high, I think some of them might escape the actual process during the during checkpoints. I think that is the reason why we do have a max, which is based on the principle of apoptosis. I think some of the cells might escape. I think that could be a fundamental reason why we use max in the clinical application.
But has max really shown efficacy?
Well, I'm not a first-hand user, ma'am. I think
Dr. Hetal has some experience on that because in Nova they are using max.
I would say max we have used, we have analyzed, and our analysis says that if max is applied indication based, then definitely it helps. I mean, indication based means if the previous history tells you about recurrent implantation failure or miscarriage or anything. So in these cases, yes, max has helped significantly.
If I may add to it, though not done a study, what we have seen is first coming to ma'am's answer, a question like this, as far as I know, there's no well-defined cutoff limit as of now for apoptosis that beyond this level it gets damaging. Second would be what Dr. Sanket had said. Yes, max is the outlook for it. Like when max does is it's removing your apoptotic cells only as such. It's not removing your high DFI cells per se, but it is removing your apoptotic cells per se. So that is one of the way when we look, then max is giving you better results, then definitely apoptosis is causing a problem over there. And third thing would be max as such, like said by Hital Shukla, that it's not going to give you good results with everyone, but very selective indicated cases where there is high DFI, repeated failures. And what personally I have seen is, especially when it is applied to oats patient with high DFI, it is really doing very good when you apply max to oats with high DFI.
Yeah, thank you so much, Dr. Akash and Dr. Fariza and Dr. Hital.
I
think because time, because of time strain,
Dr. Charu is not there. So
yes,
you have to moderate
sir.
next session also.
Fine, sir. Fine, sir. Thank you so much, all. And to take the session forward, I will be introducing the next speaker. That will be Aparna Bajpai. Can we have the slides, please? Can I have a CV, please?
Yeah, hi.
Yeah. So Dr. Aparna is a very good friend of mine, and she is currently she has done her MSc in biotechnology and working as senior clinical embryologist at DHA, IVF Fertility Center at UAE, and she has been working in the field of ART from the last 1 decade, and she is facilitated with the IMA Vivaldi for her dedicated service in the field of ART, and national faculty of ISAR and ACE, and past senior clinical embryologist at Fortis Bloom IVF Center, Gurgaon. And she has been published a review article as a co-author in 2015 in Fertility Science and Research, and she's been presented an oral paper on a tail of tailless sperm, a case report in the year 2015. And her area of interest remains cryopreservation, ICSI, embryo biopsy on day 3, day 5 for PGT as well as sperm function assessment. And she's been obtained a training from IIRRH, BACC Healthcare, Bangalore. And she organized andrology and immunology workshops under IFS Hope. Welcome, Dr. Aparna, and over to you.
Very good evening to everyone. Is I audible?
Yes, you're.
या तो इसको ये बैड को पीछे करना पड़ेगा.
Rahul, I would request you to please unmute yourself. Please go ahead, Aparna.
Yeah. So my screen is shared because I cannot see. Sorry, just a second.
You can go to slideshow mode.
Yeah, thank you so much. Thank you, Sanket. Very good evening to everyone, as we are already behind the time. So I'm just trying to wind up early. So today's my topic is advanced sperm preparation techniques for the sperm DNA fragmentation. So the question is the sperm ready for the fertilization at ejaculate? Answer is no. So we need sperm preparation techniques. And for that, I'm going back to the basics, to the basic techniques that we are already using. So what are the advantages of sperm preparation? It separates motile and morphologically normal sperm cells. It induces capacitation, and the media has provided nutrition and improves sperm motility. It reduces the chances of pelvic infection and removes prostaglandin that can lead to uterine contraction, significantly reduces viral load, removes antibodies and antigenic proteins, and it removes toxic bioactive substances. Sorry. It's not moving.
Try to press on the center of the screen and try to go to the next slide.
Thank you. Okay, so selecting the sperm preparation technique. So it is critical the sperms are separated from the seminal plasma within 1 hour of ejaculation to limit the damage from product of non-sperm cells. Semen sample should be liquefied completely before any processing is done. A normal ejaculate contains a large number of defective spermatozoa and granulocytes, which on centrifugation can generate a high number of ROS that can lead to sperm DNA damage. So ROS directly attack to the fatty acid present in the plasma membrane of sperm cells that will cause oxidative stress, that will damage the sperm function, and ultimately it will decrease the fertility potential, or it will initiate the defective genome that will and it will inhibit the developmental failure of embryos after 8-cell, that is cleavage stage embryonic genome activation. Now, how do we select the semen preparation techniques? It depends on volume, viscosity, motile sperm count, presence of leukocytes and other cells and debris. So how do we select? There are 3 methods that we are already using. That is overlay method that based on self-migration of spermatozoa. Other is swim-up technique that based on self-migration of spermatozoa and centrifugation. Third is density gradient that I think everyone is using, that is based on different density gradient preparation. Now, this is the overlay method. I'm not going to the deep. So advantages of this technique is no centrifugation, so no damage to spermatozoa, but disadvantages, it is useful only in samples with normal semen parameters, especially high degree of progressive motile spermatozoa, cannot be used for viscous sample. Now, this is the swim-up technique. So everyone is doing, I'm not going to explain the technique. The principle of swim-up technique is the innate capacity of motile sperms to migrate against gravity is used to select a motile sperm population. The advantages of this technique is good number of highly motile sperms are recovered, easy to perform, and it's cost effective. But disadvantages are it is restricted for normal or marginally abnormal ejaculates only, as it does not separate morphologically normal sperms from abnormal ones. There is a low yield and sperms may be significantly damaged by ROS. Now the last is density gradient centrifugation. Here the techniques that everyone is doing in our lab. So the principle behind density gradient technique is it separates sperms based on their density. So morphologically normal spermatozoa density is 1.10 gram per ml, and the morphologically abnormal spermatozoa density is 1.06 to 1.09 gram per ml. So advantages, it's usually a clean fraction of highly motile sperms, active motile sperm at the bottom and immotile sperms and the debris at the interface. A sperm from ejaculate with very low sperm density can be separated. Leukocytes are eliminated to a large extent. ROS is significantly reduced comparative to the swim-up and all other techniques. Disadvantages, production of good interface between the different media is a bit more time consuming, a bit more expensive, potential risk of endotoxicity from colloidal silica particles, that is quoted with the PVP deleterious effect on sperm membrane that will affect the sperm fertilization rate, and using the saline coated silica particle instead, no perfol. Now here's the topic. Reactive oxygen species. What are these ROS? So reactive oxygen species are metabolites of oxygen. The superoxide, anion, hydrogen peroxide, hydroxyl, hydroperoxyl radicals, and nitric oxide. When it presents in excess, it induces the oxidative damage to the cell membrane and to cell DNA. In the human ejaculate produced by spermatozoa with excess cytoplasmic droplets, and by the leukocytes present in the seminal plasma. So reactive oxygen species, there is a sensitive luminometer is used to measure low amount of light that generate by human spermatozoa in the presence of a redox sensitive chemiluminescent probe such as luminol, but it can be reduced by the administration of antioxidant, change of lifestyle, correction of cause like varicocele surgery. There are some DNA integrity tests that are already discussed by Dr. Hekel. So these are actinium orange, comet test, SCSA, SCD, tunnel test, chromamycin A3, in situ translation, and toluene blue. Now the new kit on the blog. So the main goal is development of new technique with the aim to enhance the preparation of spermatozoa and to select in a more accurate fashion spermatozoa carrying all the information for the future development are mandatory. So the advanced techniques now I'm going to the advanced techniques from the basic techniques. But why do we need these advanced methods over the old methods? Because we have to achieve better pregnancy outcome. That's the ultimate goal of our ART field. Now the advanced preparation techniques including microfluidic sperm sorting method and the magnetic activated cell sorting methods. There are some other methods, but these are not for the sperm preparation. These are for the sperm selection to reduce the impact of sperm DNA fragmentation and to improve the embryo development and live birth rate. These are HAXC, that is sperm slow, or the PIXI, and zeta sperm selection and electrophoretic sperm selection that is based on surface charges selection. There's a one paper by Cochrane Library that is Advanced Sperm Selection Techniques for Assisted Reproduction by Sam Lepin. So I have gone through this paper, and they have the author has concluded that the evidence suggests that sperm selected by hyaluronic acid binding may have little or no effect on live birth or clinical pregnancy, but may reduce miscarriage. We are uncertain of the effect of zeta sperm selection on live birth, clinical pregnancy, and miscarriage due to principally to the very low quality of the evidences for these intervention. We are uncertain of the effect of other selection techniques on live birth, miscarriages, or pregnancy rate. So now I'm moving to the microfluidic sperm sorting system. So microfluidics is the science and technology of accurate manipulation of small amount of fluids, which is typically done in microchannels with dimension of a few hundred micrometers. Microfluidic devices are often called micro total analysis system, that is microTAS, or lab on chip, LOC. Selection of sperm is important because the quality of selected sperm influences the success rate of ART, rate of birth defect, and has been linked with potentially infertility in male offsprings. There are essentially two concerns with conventional sorting methods, that they bypass the natural barriers that sperm would experience in vivo. And many studies have related the centrifugation step of the sorting process with sperm DNA damage that may have long-term effect on embryos viability. This is in this slide, I'm just showing three kind of microfluidic devices, but basically we are not using all these kind of microfluidic devices. So microfluidic sperm sorting approaches can generally be sorted into three categories: type 1, type 2, and type 3. So type 1 is microfluidic devices that isolate only motile sperm. Here you can see this is type A. Type 2 is microfluidic devices that isolate sperms without relying on sperm motility, but instead use sperm shape, size, or other physical biomarker as the trapping or selection mechanism. That is B, this one, the middle one. Now the type 3 is microfluidic devices for the observation and selection of individual sperm. And this I have taken from the paper by Simul et al. The paper title is Microfluidic Based Sperm Sorting and Analysis. Now, so I'm moving to type A, type 1, that usually we are using in our lab. So type 1 is the largest group of microfluidic devices and include technologies that improve the swim-up method by translating the process of motility screening to a microfluidic system. It is able to select enough sperm cells for intrauterine insemination, around more than 10 million sperms. The vast majority select a much smaller and purer subpopulation that is fit for in vitro fertilization, around 1 million cells. The subpopulation that these systems select is nearly 100% motile and is of higher quality in terms of morphology and DNA integrity than the unprocessed semen sample. I have gone this paper that in a previous slide, I have shown the diagrams of different kind of chips. So this is the microfluidic based sperm sorting and analysis for treatment of male infertility by Raheel Samuel. This paper was published in 2018. Now moving to this paper. Actually, after this paper, we have completely shifted to microfluidic sperm sorting system in our lab since 2019. So this paper was published by Palermo. A treatment approach for couple with disrupted sperm DNA integrity and recurrent ART failure. So the objective was this paper is to test a novel method to select spermatozoa with high chromatin integrity. And it was a comparative analysis. Here you can see the result. A total of 23 men had an average SCF of 20.7 plus minus 10% around 30%. After DGS, density grading system, and microfluidic sperm sorting, the SCF was 12.5 plus 5% and 1.8 plus minus 1%. It reduced after DGS and microfluidic sperm sorting respectively. So after density gradient, it reduced to 12.5 plus minus 5%. And after microfluidic sperm sorting, that reduced to 1.8 plus minus 1%. So in couple who underwent ICSI, the average sperm chromatin fragmentation was 28.8 plus minus 9%, which fell to 21.0 plus minus 9% after density gradient and 1.3 plus minus 0.7% around like 2 to 2.5%. After macrofluidic sperm sorting system. So 4 couples underwent 11 ICSI cycles with TGS and achieved 1 pregnancy, that is 25%, that resulted in pregnancy loss ultimately. And in 4 subsequent ICSI cycles with microfluidic sperm sorting, an ongoing clinical pregnancy rate of 50% was achieved. So 5 additional couples underwent 12 cycles of ICSI with density gradients system. After pre-implantation genetic testing for aneuploidy, this is quite very interesting. That's why we have shifted. So after pre-implantation genetic testing for aneuploidy, 30.3% of the embryos were euploid and 1 pregnancy was achieved. So resulting in pregnancy loss. With microfluidic sperm sorting, it reached to 31.5% of the embryos were euploid and 4 couples obtained a pregnancy finally. So 16 couples underwent 20 ICSI cycles solely with microfluidic sperm sorting system at their facility. And of these couples, 8 had failed 13 ICSI cycles with density gradient elsewhere that they have taken in their study. So these couples achieved an overall implantation of 34.5%, that is 10 out of 29, and a pregnancy rate of 58.8%, that is 10 out of 70. So the conclusion of this study was microfluidic selection yielded spermatozoa with optimal genomic integrity and improved chances of obtaining a euploid conceptus. And we have seen in our facility as well, because we are doing routinely biopsies for all our patients, that we are getting more euploid embryos since we have started using microfluidic channels, microfluidic sperm sorting system. So this is a kind of microfluidic chip that is called Fertile Plus. This here you can see the Fertile Plus diagram. This is a device. So this Fertile Plus device is suitable for IVF ICSI and frozen semen sample and IUI. So how you will start? You will incubate the sample for liquefaction at least for 15 minutes. Then you will open the device. Use the 1 ml syringe to draw 850. You can see here in the diagram. Syringe to draw 850 microliter aliquot of liquefied semen sample. If there is an insufficient volume, add sperm washing medium to give 850 microliter. Take approximately 850 microliter of semen sample from the sample container with the help of an injector. Be careful not to get air bubble into the syringe while taking samples due to dense structure. These bubbles will cause volume loss and affect the performance of device. Hold the syringe in a vertical position. Carefully insert the chip into the inlet and apply gentle pressure to achieve a seal. Be careful to avoid the formation of bubble under the membrane. Now, prepare a fresh syringe with 750 microliter of sperm washing medium. Cover the, here you can see, cover the entire upper collection chamber. Ensure an uninterrupted flow of the media over the membrane and the outlet port. Incubate the prepared device at 37 degree for 30 minutes. If you are using Hippies buffered media, then you can use, you don't need a CO2 incubator. If you're using bicarbonate media, then you can use 5% CO2 incubator for the incubation period. After 30 minutes incubation, insert a fresh 1 ml syringe to the outlet port of device and slowly aspirate a maximum of 500 microliter of sperm containing fluid. Then transfer the collected material to a cup tube and store for a later use according to your lab practice. Now this is a different device. This is called Fertile Ultimate Microfluidic Preparation Device. And this Microfluidic Fertile Ultimate device is suitable for IUI, frozen semen sample, and the same process, you will incubate the sample for the liquefaction at least for 15 minutes. Use 5 ml syringe to draw a 3 ml aliquot of liquefied semen sample. If there is insufficient volume, you can add sperm washing solution to give 3 ml volume, and take approximately 3 ml of the semen sample from the container with the help of an injector. Be careful not to get air bubble into the syringe while taking sample due to its dense structure, because these air bubble will cause the volume loss and it will affect the performance of microfluidic device. Hold the syringe in a vertical position as it's shown in the diagram. Carefully insert the tip into the inlet and apply gentle pressure to achieve a seal. Be careful to avoid the formation of bubble under the membrane. Prepare a fresh syringe with 2.5 ml of sperm wash media. cover the entire upper collection chamber, then ensure an uninterrupted flow of the media over the membrane of the outlet port. You can see here in the diagram. Incubate the prepared device at 37 degrees centigrade for 30 minutes. If you are using HIPPIes, again, you don't need CO2 incubator. If you're using buffered media, bicarbonate buffer, then you can use 5% CO2. After 30 minutes incubation, insert a fresh 5 ml syringe into the outlet port of the device and slowly aspirate the maximum of 1.5 ml of the sperm containing fluid. Then transfer the collected material into the cap tube and you can use. These charts have provided by the Fertile website, actually, I've gone through. So they have published some data related to their device that there's a less oxidative stress while you are using the Fertile Plus device, and there's a more amount of oxidative stress in the sample while you are using the swim-up technique or density gradient. This is the kind of comparative study. Also, they have shown in their data that there's a higher nuclear maturity in microchip sorting system after the sorting, and there's less nuclear maturity in the raw sample. Here you can see the slides that they have shown. Here the sperm viability, it is also related to the sperm viability, that after chip sorting, you will see that viable sperms are more and all the debris and the dead sperms are already eliminated. So sperm viability also higher in the after the sperm sorting system. Now moving to the magnetic activated cell sorting, as now everyone was discussing about this thing, apoptosis and MAX. So this MAX is based on the sperm apoptosis. This selection of non-apoptotic sperms for use in ART is based on the presence of phosphatidylserine on the external surface of the sperm membrane in the early stages of apoptosis. So this is kind of a biomarker. If the cells is going to apoptotic, then there will be higher higher amount of phosphatidylserine on the external surface of those sperm cells membrane. Magnetic activated cell sorting MAX and glass pool separation columns utilize the magnetic property of phosphatidylserine to separate the apoptotic sperms from non-apoptotic. That is published by Grunwald in 2001. Here you can see the diagram. Like these are annexin V magnetic column, and this is phosphatidyl. These these are the phosphatidylserine, which are present as a biomarker. Okay, so now the externalization of phosphatidylserine PS to the outer surface of the sperm membrane, a feature of early apoptosis, has been used as a basis for the selection of non-apoptotic spermatozoa because you can differentiate them. The externalization of PS allows for its binding with annexin V and conjugated paramagnetic microbeads, which could be used to label and separate apoptotic spermatozoa using a magnetic activated cells sorting system, that is MAX. This is published by, again, Grunwald in 2001. Now, since MAX does not have the ability to remove leukocytes or debris or any immature germ cells present, so the technique was used in conjunction with the DGC to exclude the seminal plasma and other contaminants. Said et al. In 2005, they have published. So combination of DGC and MAX will involve repeated steps of centrifugation and resuspension, which might be detrimental when applied to semen sample, characterized by the limited sperm count as low sperm recovery by the expected. That is said et al. In 2008. Here you can see the diagram. I have notified here. The column A, the diagram A is showing the column that contains steel sphere placed inside an external magnet. This is the B is a non-labeled cells flow through the column to be collected, and the immunomagnetic labeled cells remain attached to the magnet. Here you can see the cells are attached. Remain attached to the magnetized spheres and are retained inside to the column. Now, the combination of MAX with DGC yields a clean separation sperm population characterized by the higher motility, viability, morphology, reduced apoptosis manifestations, that is including sperm DNA fragmentation as well, and increased cryosurvival rate. That paper has published by Agrawal et al. In 2007. For IVF application, the selection of non-apoptotic human spermatozoa after MAX, you can use it, but the conclusion on is it improves sperm fertilization potential as per said et al. They published in 2008. It increases cleavage and pregnancy, it increases cleavage and pregnancy rates in oligostenospermic ART cases after ICSI, resulted in an ongoing pregnancy achieved with a clear reduction in the percentage of sperm DNA fragmentation. That was a case report by Reva et al. In 2009. May be considered as a molecular preparation technique that complements conventional sperm preparation protocol DGC and may enhance ART success rate, but there is no clear data. Okay, and nevertheless, the value of integrating MAX in sperm preparation prior to ICSI and IVF requires further investigation in a clinical ART program by Agrawal et al. So now the take-home message. Before going to take-home message, I would like to discuss more about the microfluidic, because microfluidic is really good sperm sorting system, sperm preparation techniques. So you can use it for the IUI as well, which patient have multiple failures, and you can also use for the ICSI in the cases where the patient have multiple time of failures, because anyways after doing multiple tests and clinical tests, these assay and all, you have to give some kind of treatment. So in the lab, you can give them a best treatment. Now the take-home message is, for the time being, the take-home message is that DNA damage in the male germline is potentially damaging. So the care should be taken. And when treating patients exhibiting such damage with ICSI, in light of such consideration, it would seem rational to try to determine the cause of DNA damage in the male germline and to do everything possible to alleviate these damages. You can give antioxidant therapy, you can use sperm isolation techniques, or you can offer patient either you going for the TISA or the surgical retrieval of sperms for the ICSI, or you can split the case as well, because in some patients we have splitted also, like you can do half with the ejaculate sample and you can do half with the teaser sample if patients have multiple times of failure and there's a high DNA fragmentation in the sample. So sperm isolation techniques that will select for gamete processive very low levels of DNA damage. So here it is. Thank you.
I think Charu sir is with us. I think, sir, you can take over, sir. Charu sir?
Charu is in hospital actually, no?
Okay, sir. So yeah, I think we can proceed to the next lecture, sir. Due to time limitation, I think we'll be not taking any questions. Apologies for that, and we'll be proceeding to the next series of lectures which are lined up. I think I'll hand over to Dr. Nancy. Nancy, unmute yourself.
Your sound is not coming.
Thank you, Dr. Sanket. Now moving towards the next section, which is demonstrations of AFI. To introduce other speakers. Deepu, please.
Deepu is there, na? Deepu, please.
Yes.
Thank you, Dr. Nancy. Let's move the last session of the evening, which are demo on sperm DNA fragmentation tests, microfluidics, and MAX. Moderate the first demo. I invite Dr. Hital Shukla sir. Sir is chief andrologist from 2015 onwards and managing andrology lab, structure training of new androtechs, IUI workshop and other in-house workshop to train, update the androtechs. Over to Dr. Hital sir.
Dr. Hetal, your sound is not coming. Your sound is not coming. I think there is problem with sound now.
Yes, sir.
I think we can start demo. The first speaker is Rahul Sisodia. He is MSc in microbiology, embryologist at Southern Fertility and IVF, Basant Vihar, New Delhi.
Hello,
Yes,
hello.
Dr. Hetal, please. Dr. Hetal, you can start. I think he will take over after that demo. Na? I can start with this. Dr. Hetal, I can start in the meantime. Just try to log in, log out and log in again. Dipu, you can start his video.
Okay, sir. Okay, sir.
Hello.
Is it visible, sir?
Good evening, everyone. And thank you so much, Ayeda and Dr. Weiss, for this opportunity. And my name is Rahul.
Sir, the video is not visible, sir. Sorry to interrupt.
Vision.
Please stop share and click on the screen and share, sir.
Okay.
Entire screen and share.
Is it visible?
Yes, sir.
Okay, thank you.
Thank you.
Good evening, everyone. And thank you so much, Ayeda and Dr. Weiss, for this opportunity. And my name is Rahul Sonia. I am employed at Southern Fertility. Today I am presenting them on some DNA fragmentation test. This is coated glass slide. First place glass slide on flat surface and take one cover slip for one glass slide. Incubate across gel to 880 degrees Celsius for 10 minutes. Mix the sample very well. And take 60 microliter semen sample. Microliter semen sample in agarose gel tube and mix very well. Take 20 microliter semen sample. Center. Put cover slip on glass slide and without air bubble. the slide in refrigerator for 5 minutes. After 5 minutes, remove the cover sleeve. Slowly. And don't disturb palate. Solution and add few drop of new natural solution. Cover all area and wait for 6 minutes. After 6 minutes, next step is lysing solution. Add few drop. And discard the water. Clean backside from the filter paper. wait for air dry naturally. After air dry, examine the stain smear. Count only 200 sperm cells. Under a microscope, 40x objective lens. Microscope view. This is normal and abnormal sperm. See the picture and see the normal value. Thank you so much.
Sir, please give your comments on this. Dr. Hetal, sir.
Hello.
Yes,
sir.
Dr. Hetal.
I am audible?
Yes, sir. Yes, sir.
Okay. So thank you, Rahul, for a very good video presentation of the sperm chromatin dispersion test. I would like to ask you one thing, that is there any importance of adjusting sperm concentration before you add to the agarose? Is Rahul there? Yeah.
Yes.
Yes, sir.
So
I think, Dr.
is
Hetal,
there any importance of adjusting sperm? If lot of spermatozoa are there, sperm concentration is too much, then it will be, slide will be very much crowded.
Yes, Dr. Hetal, you have to give final comments on this.
Okay, so around, sir, 15 million per ml.
Exactly. That's good. That's good. Yeah. That's what one needs. And how will you make sure that medium halo is not counted as a small halo, and small halo doesn't go to the medium one? So one must be.
Please.
Yeah, one must be very careful when they are scoring the halo size, because here one need to be very particular. Large halo, there is no doubt. No halo also, there is no doubt. And there are only 4 categories: large, medium, small, and no halo. So large halo you can differentiate, small halo you can differentiate. But to differentiate medium halo and small halo, one need to have a very clear calibration of the halo in reference to the core size of the sperm head, and that is up to the 1/3 of the core size. It is equal or larger, then it is large halo. Then up to 1/3 it is the medium halo, and smaller than that it is considered as a small halo. So I think if everyone keeps in mind, then this can be taken care, and medium halo and small halo, because these are very critical. If medium is counted as small, then percentage of fragmentation may change. So with this, I think, yes,
Sir, small size is
Rahul.
one part, sir.
Yeah, very good video presentation. Thank you very much.
Thank you so much, sir.
Thank you so much, Dr. Hetal, sir, and thank you, Rahul, for wonderful presentation. Now move on to next demo. I invite Dr. Rahul Sen, sir. Dr. Rahul Sen is currently working as a chief clinical embryologist in Nilpan facility, Jaipur.
Dipu, we can start with the video. The time is already short.
Sure.
The video. Start. So to introduce, there is a video presentation from Alicia. She'll be presenting on microfluidic, right?
Yes, sir.
You can start the video.
Okay, sure.
She's MSc in clinical embryology. Let's see the video first and then we'll discuss it.
Okay.
Good evening to everyone. First of all, I would like to thank Team iHera for having me here.
Deepu, please share the
Sir,
screen.
video
Yeah,
is not
yeah,
seen,
yeah.
sir.
Video is not visible.
The topic
Yes, sir.
given to me for demonstration.
Video is not visible.
Okay, sure.
Yeah, yeah.
Before that, I would like to talk briefly.
Share entire screen.
Yeah.
Is it visible, sir?
No, it's
No,
not
no.
visible. What you can do is
share the
you can
entire
stop the
screen, sir.
sharing,
Okay.
restart the sharing again, and then share it as a whole screen. Yeah, share screen. Yeah. Now you can start.
Good evening to everyone. First of all, I would
Sir, is it visible?
Yes, sir. Yes, sir.
Yes.
Thank
like
you.
to thank Team iHera for having me here and Dr. Ved for
Deepu, can you increase the voice? Voice is not audible of the video.
Sir, while sharing, please enable the audio and share, sir. Please stop share.
via the ciliated epithelium.
While sharing, in bottom left corner, there is a share sound.
Okay. Just a
Please
minute.
click that, sir. And then share the entire screen.
Screen.
Good evening to everyone.
Sir, is it visible?
Visible and audible. Just play.
Just.
First of all, I would like to thank Team iHera for having me here.
Not it, sir. The voice is, we can't hear the voice.
No, I think we can hear it.
For demonstration is microfluidic sperm sorting device. But before that, I would like to talk briefly about the basics of this technique. We know that in vivo, the gametes are exposed to the constricted moist environment of the female reproductive tract, which is surrounded by the glycoproteins as they gently move via the ciliated epithelium. But whereas in labs, artificial manipulations impose external stress on the gametes, which cause these osmotic imbalances, temperature shifts, mechanical stress, and pH fluctuations, which may have negative effects on the embryo quality. So we need newer approaches that will mimic the in vivo conditions of the female genital tract physiology. So it will impose less external stress on the gametes, therefore better embryo quality provided. Microfluidics refers to the technology utilizing characteristics of fluid movement in a micro or nano environment. They rely heavily on variables of fluid properties such as density, viscosity, velocity, and size in a microenvironment. It is an emerging technology in ART and already has applications in sperm preparation, oocyte denudation, embryo culture, IVF, and vitrification. The two main properties of the microfluidic platforms are laminar flow and their passive diffusion across the microchannels. At the macro level, the fluid flow on a normal environment scale is turbulent and the stream of fluid is unpredictable. Just imagine a water gushing out of a broken tap. So that is what turbulent flow is. But in microfluidics, laminar flow is achieved within the decreasing dimensions of microfluidic channels. Fluid flow streamlined in a parallel manner and has predictable flow patterns. The second most property is the diffusion across the interface. Before that, you would wonder how the laminar flow takes place. So, in the simplest of microfluidic platforms, this laminar flow is automated by gravity and hydrostatic pressure in different inlets or by a syringe pump. So, in the laminar flow, parallel movement of multiple streams of media occur at the same time without mixing. So, between these channels, a continuous interface appears, so which allows the particles or cells to pass by diffusion or by active movement across the interface. Coming to the application of microfluidics in andrology, it is used for the sperm preparation for ICSI. It is based on the studies that reported physiologically and genetically perfect sperms exhibit a higher grade of forward motility. So our main aim is to get highly motile sperms, but though the conventional sperm preparation methods such as the simple watch, swim up, and density gradient gave us high motility, but they were reported to induce sperm DNA damage, perhaps due to the exposure to reactive oxygen species, which was caused by centrifugation. So the newer preparation techniques like microfluidics does not require centrifugation and does not add to the DNA fragmentation. It is natural selection based and not centrifugation. The benefits of microfluidics in andrology is that it approaches to mimic the female reproductive tract for sperm selection. This is because the sperm moves across the microchannels in this device just as it moves in the female reproductive tract where it is selected. The recovery of highly motile structurally normal spermatozoa with good DNA integrity is obtained. Does not need expertise to perform. It is time saving and it could be used for all kinds of semen parameters. Indication: it is used in teratozoospermic, oligozoospermic, and patients with high DNA fragmentation. It is also used in patients with previous failed IVF cycles. These are some of the articles that support the microfluidic sperm sorting. This is the design of a microfluid sperm sorting device. The fluid flows in this through microchannels. It has two inlet ports, that is A and B, and two outlet ports, C and D. There are two parallel laminar flow streams from A to D and D to C, which forms one area, and the fluid flow is passively gravity driven, and sperm sorting is based on food. Let's know how this device works. So what we do is we place the semen sample in the first inlet portal, that is A, and then we place the fresh washing media in the second inlet portal. The fluid is allowed to pass through all the chambers. Then the interface between the diluted semen and the fresh media only allows the motile sperms to pass through it through active movement. Therefore, the sperms from the A inlet get selected in the outlet C reservoir. This way, the other outlet portal, that is D, contains the debris, down cells, and the non-motile sperms. Now we're going to start with the demonstration using the Wallace sperm sorter. Before that, these are the requirements we need. Start preparation by allowing the semen to completely liquefy. Warm the sperm washing media to 37 degrees Celsius before use. To prepare for dilution of the semen sample, take a conical tube, label it with the patient name and ID. Dilute the liquefied semen with washing media at 1:1 ratio. Keep the suspension aside at 37 degrees Celsius till it is to be used. Now the preparation is done. Take the Wallace sorter kit. Open the pad. This needs to be fixed in a 60 mm dish. Gently press it by fingers and fix it into the dish. Now load 100 microliters sperm washing media into chamber A of the sperm sorter. By doing this, make sure to avoid the entry of any air bubbles. Keep the micropipette straight. Now allow the media to flow the other chambers. Load another 100 microliters sperm washing media and load it into chamber B, C, and D respectively. Now pull out all the sperm washing media from all the chambers back. This step was needed for filtering the chamber. In case there is any blockage across the channels, we would come to know. Now load 20 microliter of the sperm washing media into chamber C and D respectively. After this is done, now take the sperm washing media and load 100 microliter into chamber B. Load 65 microliter of sperm suspension into chamber A. So now we have loaded the media and the sperm suspension. After this is done, close the lid of the dish and allow the coiled sperm sorter to stand for 30 minutes in the incubator. After 30 minutes, you can take the sperm sorter out. Now we extract the completely isolated spermatozoa from chamber C. Now this sample is ready to be used for ICSI. This is the microscopic view of the sperm sorter. You can see the sperm moving from the inlet chamber A, and that is the stream from B. This is central interface from where the motile sperm from chamber A is migrating into chamber C. You can see the sperms flowing. The ones which can cross the interface, only the motile ones. This is the reservoir C where the motile sperms are collected, from where we aspirate it for the use in ICSI. This is the chamber D, the poor quality sperms are moving from A, and this is the reservoir at chamber D, where you can see all the immotile sperms, debris, and round cells are collected. The limitations of this device is that it is a low volume processing device which could only be used for ICSI. It works fine for ICSI because since the total sperm cell count required for microinjection is low, we don't need to put the entire sample for processing. But in case of IVF or IUI, this needs to be improved. Other than that, there are clogging and sample viscosity issues, because of which the sperm cells may get accumulated at the bends of the channels, and if the sample is too viscous, there could be issues with the flow. And third is that the higher cost is there as compared to other conventional preparation techniques. I reached the end of the PPT, and let me summarize it. So the number of people in need of ARTs is growing, and we all know that about half of the infertility cases are alone attributed to male factors. So it is clear that microfluidics offer many opportunities to revolutionize the analogy technique, and therefore it allows for selection of the higher quality sperm, leading to better improved quality of the embryos. It also provides an environment that is more suitable to gamete and embryo function, and ongoing research is likely to lead to new techniques in sperm sorting. And I feel that in the long run, microfluidics may completely replace the current centrifuge-based methods. Thanks a lot for listening.
Thank you so much, Alicia, for this for creating this wonderful videographic presentation for all of us, and exploring and explaining each and everything about the microfluidics, how it is actually works, and how it can be useful in our routine daily to day practices. To summarize this presentation, microfluidics actually it was introduced in IVF for the purpose of sperm sorting, means to separate the healthy population of motile spermatozoa from the non-motile and the abnormal cohort. Later it was found that these motile group of sperms, they are actually having less DNA fragmentation, so it was like an add-on advantage of this technology. But yes, in the last slides Alicia has already mentioned that this technology has few cons as well, means it cannot be used in low volume samples, in the high viscous samples, even in some cases of high or severe kind of astenospermia. So in those cases this technique may be means not suitable for the purpose of sperm separation. So yes, we are still naive with this technique. This technique has lot to explain and lot to explore, so let's see how it goes on. The current data shows this technique has advantage on the over the conventional preparation methods, but the day-to-day practices and the reproducibility of this technique has yet much to explore. So thank you, Alicia, for this wonderful presentation, and over to you, Deepu.
Thank you, Dr. Rahul sir and Alicia, for this presentation. This is the last demo. I invite Dr. Akash Agrawal. Please share the CV, please.
Deepu,
I think we can stop.
Akash starts, I wish to ask a question to Alicia.
Okay, sir.
Alicia, is this sperm sorter device available anymore?
Sir, actually we have this device already in stock. We have been using for a while, so I don't know about like buying it again. I don't have idea about that, but we already have a lot of kits available with us in our lab, so we have been using it.
Oh, lucky you. So anyone can comment
I think,
whether it is available.
Dr. Shuklaji, you are right. Now it is not available. I think they are not supplying now. That earlier the SAR people were supplying this. But you know that Deepu has ordered so many kits available with us. So sometimes we are using, not regularly, but of course, yes.
Okay.
Sometimes we are using.
Okay.
Lucky people, sir.
Akash, please start.
Sir, yes, sir. Thank you, sir. I was just telling Deepu that we'll skip the intro part. We are already late. He can introduce the speaker. Yeah. We'll be having a video demo about Max, a short demo at that, straight away to the Max. It will be given by Ms. K. Vasavi. She has done her MSc in microbiology from JT University. She has done her observership and training in embryology and andrology at Nauroji Wadia Hospital, Mumbai, and she is presently working at Hegde Fertility, Madhapur, Hyderabad. So, Deepu, if you can share the screen for the video, please.
Okay, sir.
Ms. Vasavi, you can sit on your screen.
Is it visible, sir?
The video has not started. Yeah, the screen is visible.
Okay, sir.
I think Deepu, you have to share again that entire screen. Then it will be available. Deepu.
Yes, sir.
Again, you have to share. Like entire screen, you have to share. Whole screen.
Okay, sir. Sir, is it visible?
Yes, sir.
Yeah, it's visible.
मेरे में भी दिखा। Akash, do you have that video?
The sound is not visible, sir.
I think Deepu has to unmute the volume button.
Yeah, Deepu.
Yes, sir. Sir, volume sound is full.
Yeah, now it's come. When you pause, it has come.
Don't mute yourself.
Deepu, keep unmuted yourself. Yeah.
Oh,
start
Deepu,
the video.
Deepu, unmute yourself.
Deepu, unmute yourself.
Bas.
Now play the video.
Okay.
Max means keep it for 20 minutes incubation and run the column and then check for the count and motility. We start with the procedure now. This is the raw samples count and motility. So this we will be doing density gradient. Density gradient for this. After density gradient has been done. Now to the density gradient pellet, we will add annexin B.
So what we have seen that over here, max usually we follow it with your density gradient, so it helps in the procedure as such, and it requires such a pre-requirement in most of the cases, otherwise the sample won't turn out good.
Buffer to the corner. It's been 20 minutes of incubation. Now will replace this with one more new tube wherein we collect the sample. And now add the incubated sample to the column. This will take around 10 to 20 minutes. Sometimes it might be slow due to any debris present in the sample. In such cases, if it is taking more time, you can just, with little push, you can use a piston and then push it.
So what was the initial view?
Down the column, take 1 ml of the buffer and add it to the column so that you can wash out all the sperms present here. And collect in the same tube. Once the buffer runs down completely, you can remove the column and discard it. Now we will check for the count and motility of this. This is a max process sample. This sample can be used for further process like IUI or IVF or GC. That's all. Thank you. Hi everyone, I'm Vasvi. I'll be telling you about
Thank you, Tipu. Thank you, Ms. Vasvi. So we have seen the second part of the video where we have seen that how max is done. It's a simple technique, literally not much of an increased task. Yes, time-wise you will be consuming another half an hour extra. The main thing would be it requires a pre-technique like a density gradient, so your process comes out better. After you do the density gradient and create a pellet which is rich with the motile sperms, usually you should get in excess of 90%. Then what she has shown is you adjust the max stand over there, put the column over there, and you rinse it through. Just to sum it up, she'll pass it through so that you rinse the column over there. So any static and any debris from the manufacturing is just filtered out, and the very smooth passage of the max beads to come out. And next, she has added the max beads, which are obviously stored at 4 degrees centigrade, and you will be getting them to room temperature and adding it to the your pellet preparation, which is over there, and keep it for roughly 20 minutes over there. So what this timer does is it allows your max bead to attach to the sperms which are of interest. So here max was always developed as a surface technique where you can only separate the cells which are having a surface receptor for it. So here the receptor would be phosphatidylserine over here. So that would be identified, and that is identified in usually your apoptotic cells. So once that is identified by your max bead, your magnet will retain the cells over there. So you'll always get two fractions over there, one which is retained, one which comes out from the max column. It could be any one which is of interest to you. In this case, it's the column which comes down, the fraction which comes down, which is of interest, which is not having phosphatidylserine. So that will be a fraction which is having less of apoptotic sperm in it. So Vasvi, if you can tell like any difference in motility you see over there? with max count and motility?
Generally, the motility will be little reduced from density gradient pellet and after max. With a good sample, very low difference can be seen, but otherwise it's maybe 5 to 10% of progressive motility is reduced.
Okay. And how frequently do you face the problem of clogging of the column?
Clogging we generally see in severe oats wherein density gradient pellet is little cloudy and not done properly or something, wherein you have lot of debris, or like very severe oats where you can't do even a single layer and you directly wash it and then use that pellet for max.
So double density obviously gives better results, and it's the debris which might clog it since the column is very narrow over there. Yeah. Any other reason for it why the motility could be reduced? Something to do with the beads or washing?
Washing is one time extra, so maybe because of that.
You try to remove the beads over there. You try to remove the beads which might be stuck over to the sperm, carried forward, which might get accidental. It's a little fraction and that might result over there. So max touch as such a relatively simple technique, definitely useful in indicated cases as we have seen in the earlier presentations. Thank you so much, Krishna.
I think we have to close down now. We have to call Dr. Shiplaji for vote of thanks. It is already 8:20.
Yes.
Sir, with your permission, one last question.
Yeah.
Dr. Akash. Dr. Akash, the question is, rightly mentioned by you. See, max is basically based on one apoptotic marker, right?
Right.
But there are multiple apoptotic markers which has been expressed on the cell. But what about the missing cells? Like those express the second or third apoptotic marker. You'll be missing out those cells, right?
Yes.
So how do you defend it?
What we are trying to do over here with max, with this particular thing, is we are reducing the fraction. If you had the earlier discussion, what I had done, in that also I told they don't eliminate as such totally. You reduce the fraction over there. And right now, even this is a quite significant cost and time in addition to what is being done. So yes, if you get in market where there are more labeled beads which are there, definitely would be most welcome. But as of now, this is the only one which is there. So we have to use that one. Left with no choice.
No, I would like Sanket to develop those beads.
Yes, sir. Yes, sir. Definitely. If some company is sponsoring, especially IHERA as such, if you promote this to next level, I would definitely accept it, sir.
But the only downside of this I could sense is maybe then you may elute just a few sperms out of those. So
yes, sir. Yes, sir. Agreed.
This is the thing. But anyways, it was a wonderful session throughout. Everyone has put on very good efforts to make it very interesting. And as one can see in the question answer box and chat box, very good questions and interactions, especially from the experts like Firuza ma'am and other people. So all in all, it was very good session to learn from, and we hope to continue this thing where we involve our younger generation to come up and express their views, to share their experience with the things that they are doing in their laboratories. And of course, this platform gives you an opportunity to overcome your hesitations, your shyness, and learn how to speak, how to put up your whatever you are asked to in limited period of time, very concise, very precisely. So this is very good platform to learn, and I welcome all those people who are aspiring to come up, and I'm sure Dr. Ved will try to accommodate them in coming webinars. I have, if Dr. Firuza Parikh ma'am is still here. Is she here?
No, she's left actually.
Anyways, so thank you everyone. Thank you all the participants. Thank you audience to be here for almost 3 hours, and our support team who are here to help us out for this wonderful team, and Dr. Ved Prakash to organize this event. Thank you.
Thank you everyone. Thank you so much. Thank you.
Thank you, Ved sir. Thank you, everyone.
Thank you so much.
Thank you, Shukla. Thank you, Shukla sir. Thank you, Ved sir. Thank you, Shukla sir.
Thank you,
Thank you, the speakers.
Thank you everyone for inviting. Thank you, Ihira.
Thank you. Thank you,
Thank you, sir. Thank you, Dr.
team.
Ved. Thank you so much.
Technical team, are we offline now?
No, sir.
You can
Please take us offline.
Sure, sir.